Check. Check. Okay. Speaker tested. Okay. Beginning. On.
Sorry for the inconvenience. Om Amriteshwarya Namaha. Humble pranams on the lotus feet of our beloved Amma. It is our great pleasure to warmly invite you to the 4th Annual National Undergraduate Medical Summit, SPUST 2021. We thank Roche for making this session possible. It is fascinating to know that there are millions of cells traveling all around the body, taking care and nurturing the tissues. Today, we will deal with these multifarious cells, their differences, similarities, and abnormalities. Hopefully, we will be able to awaken the curiosity and interest of all the aspiring hematologists out there. So for today's session, we have our chairpersons, Dr. M.G.K. Pillai sir. He completed his MBBS from Government TD Medical College, Alapura, and his MD from JJM Medical College in Davangere, Karnataka. He is interested in research and has published many papers. Currently, he is a professor and head of the Department of General Medicine at Amrita School of Medicine, Kochi. Dr. Jay Kumar, he completed his MBBS from Government Medical College Trivandrum, DCH from Government Medical College Trivandrum, and also MD Pediatrics from Government Medical College Trivandrum. Currently, he is a professor and head of the Department of Pediatrics at Amrita School of Medicine, Kochi. Dr. Manoj Unni, he did his MBBS from Major Medical College, Pune, MD in General Medicine from Grant Medical College, Mumbai, and DM Clinical Hematology from CMC, Vellore. He did his fellowship in hematology from British Columbia Cancer Agency and Vancouver Coastal Health. Currently, Associate Professor, Department of Hematology at Amrita School of Medicine, Kochi. Now, Dr. M.G.K. Pillai will be introducing the topic hemophilia, and Dr. Manoj Unni will be introducing our first speaker for the session, that is Dr. Neerat Siddharthan. Now, I would like to invite Dr. M.G.K. Pillai, sir.
First of all, let me thank the students, the organizers, for inviting us for this SPUST program. Hemophilia always was a challenging problem for physicians. we had a couple of cases which had difficulties in diagnosing because most of the initial investigations were normal. Only the history tried to help us, means hereditary. So this is a inherited condition, X-linked recessive. And interestingly, there will be an abnormality in the FETT, which we will not send usually in majority of the cases. So usual presentation will be deep-seated bleeding or even abnormal swellings in the muscles or even hemarthrosis. So very interesting for the physicians with a lot of difficulty in coming into diagnosis. So I think this topic will be of great interest for the students. That too will be presented by an authority in the field. Thank you.
Now I would like to invite Dr. Manoj Unni, and he will be introducing our first speaker for the session.
At the outset, let me thank everybody here to give me the privilege to be present at this important session. I would like to introduce Dr. Neeraj Siddharthan, who is going to be the first speaker. He is alumni of Trivandrum Medical College, his MD and MBBS and MD there, followed by his BM Clinical Hematology in CMC Vellore. And presently, he holds the position of Professor and Head of Department of Clinical Hematology and Bone Marrow Transplantation. So he has been an excellent orator, teacher, and to be today presenting on the topic of ovarian hemophilia. Over to Dr. Neeraj.
Thank you, Manoj, and thank you, NGK sir, for introducing the topic. Good afternoon. And at the outset, I want to thank the organizing team, the students, and the principal for inviting me to the first session and holding a session for hematology. My topic in the next 20-25 minutes that I'm trying to cover is hemophilia. The topic has already been introduced. It's an X-linked recessive bleeding disorder, and I will start with some history and try to take you through how the disease was initially diagnosed and how the treatment has evolved over a period of last few decades, and how accelerated advances in treatment has happened in the last few years. So the way this presentation will go will be, first we'll start with some history. So I think history will help us learn so many things. And then we'll come to some little bit of therapeutics of the present. And then we'll go a little bit into the future, and then we'll stop. I'll take the questions at the end. So when you talk about the history, you can see here, this is, very old Jewish textbook of Talmud. Okay, so it actually deals with civil laws and religious laws. And this actually, they had a very keen observation that if a woman bears two sons who die of bleeding after circumcision, any additional son she has should not be circumcised. So that was a very clear instruction that they have got by observing those kind of patients. They also said that the sons of her sisters must also not be circumcised. The sons of the brothers can be circumcised. So that was very clearly how initially somebody has described the X-linked recessive bleeding disorder that hemophilia is today. But that was long back. But now we come to the era of documentation, and that started in the early 19th century. A physician by name John Conrad Otto. He provided the actually first accurate account of hemophilia in the modern medical literature. So he provided an article called Bleeders, and it was published in a New York journal. And this is an excerpt from that, and he actually had described a family with hemophilia, and it could be, the origin could be traced to a woman who settled in New Hampshire in 1720. So 80 years of history he has taken to publish that, and that was the first non-publication. This is an interesting picture. I think many of you would already know who all are there in this picture. Okay, there are three parts to this picture. I think on the right side you can see Alexei. Alexei is the most famous hemophiliac in the history. He was born to a Tsar family, and his mother was linked to the British royal family. And at that time, this disease was called a royal disease, because most of the royal families in Europe had cross-married, and the X-linked disease was manifest in many male children. Unfortunately, Alexei died at the age of 14. And on the left, you can see that is possibly the first non-physician. I probably cannot call a physician. He is Rasputin. He claimed to treat hemophilia of Alexei. So it's a controversial character. Anyway, this is the family tree of the royal family, and as you can see here, I think Alexei is coming here. Yeah, here is Alexei here, and then you can see it has been traced. Different people there are different carriers, and hemophilic affected males were there. All right, so now how to diagnose hemophilia was the next challenge. You have the family history, you know that it is X-linked recessive, people knew that, but you need to have a blood test to diagnose this. Bleeding disorders need to be diagnosed by some blood test. Now we are in 2021, but if you talk to an era 100 years back, people didn't know how to diagnose. So one of the first tests that was discovered was Prothrombin Time. And this is an article by Arnett Quick. Arnett Quick is a doctor who discovered the Prothrombin Time. Now, if you can see, before going into that, this, can you see this? This is a test tube which has been inverted, and you can see, what is this? This is a bolt, and this is a fibrin clot. In a Prothrombin Time test, this is a final clot that is formed in a PT test. Now, if this clot is formed, it is so strong that it is holding that bolt all the way up there. So that is the strength of the clot. So this initially the mechanism of hemostasis was described by a physician called Moravitz. You can see Moravitz had said that initially thrombin is generated and then fibrin is generated. So fibrinogen plus thrombin, that is two equations. So these two equations in hemostasis is what E is equal to mc square in physics is, because first equation says thrombin is generated, and second equation says it adds fibrinogen to thrombin and fibrin is generated, and then the clot occurs. And Arnett Quick described in 1935 the Prothrombin time, which we use till now. That is almost 90 years later, we are still using the Prothrombin time. Okay, now the problem is that the Prothrombin time is normal in most of the hemophiliacs. Unfortunately, in hemophiliacs, when you looked at the Prothrombin time, all the Prothrombin times were normal, but the hemophiliacs were bleeding. So there needed to, you needed to devise a new, test to, diagnose hemophiliacs. So in general, people used thromboplastin to test it. What is thromboplastin? Thromboplastin was generated from tissue of a rabbit brain. Now, people looked at decreasing the thromboplastin concentration. If you're in this graph, you see the thromboplastin concentration is decreased. Then it becomes the partial thromboplastin. So that is APTT is activated partial thromboplastin. So this partial thromboplastin, if you use, that could very well segregate between the hemophiliac. Partial thromboplastin plotted nicely in 40 seconds or 50 seconds in non-hemophiliacs, and in hemophiliacs, it was 100 seconds or 150 seconds. So that was the initial experiments which showed that, okay, hemophiliacs can be diagnosed not by prothrombin time, but by a partial thromboplastin time. So you can see the people behind, you could see the Wagner in that previous photo, and this is Langdell, Wagner, and Brinkhaus, who is a person who is standing there. These are the three people who were behind the discovery of the seminal APTT. And Brinkhaus, Dr. Brinkhaus is the person who actually found out the factor 8 is the one which is deficient in hemophilia. Now, this is also a little bit of history. You can see two very important physicians here. On the left, you see Davy, and on the right, you can see Oscar Ratnoff. What have they contributed? They have contributed to the coagulation cascade, waterfall cascade theory that both of them have. In addition, there was Dr. McFarlane also. Do you know the patient who is sitting with Ratnoff? Anybody knows that? He is Hegman. He's the first patient with the Hegman's factor deficiency. So a little bit of history there. You can see that that was how we now understand the coagulation pathway, that there's a waterfall cascade. Then we know that, we can divide it into an intrinsic pathway, which is detected by APTT, and extrinsic pathway, which is detected by PT, and the common pathway, which is detected by both PT and APTT. Now let's come more closer to hemophilia. In hemophilia, now how you diagnose hemophilia by APTT prolongation, and then you can do probably factor assay. We'll come to how factor assays are being done. But now people started wanting to treat it, because you know that the factor is deficient in the blood. Now you give blood and treat. So that was the initial treatment. You hemophiliacs bleed, something is deficient in the blood, you give blood and treat. So there were many articles like this which said how to treat hemophilia by giving blood transfusions. But plasma transfusions are also given. But it is not humanly possible to give blood transfusion for every patient with hemophilia, because you give only very little amount of factor in that. Now people started wondering whether we can separate the active concentrate that factor 8 is. So you can see Judith Graham Poole, that lady that you can see in this picture. And I hope you can recognize that blood product there. It hardly contains 15 ml of product there. That is called cryoprecipitate. This cryoprecipitate is prepared from fresh frozen plasma, and it is very much rich in factor 8. It is also rich in fibrinogen. It is also rich in factor 13. But importantly, that could be given as a treatment for hemophilia A. Please. Now, similarly, plasma could be given as a treatment for hemophilia B. So that was the initial treatment. Now people were getting treated, for bleeds. You could treat the bleeds with hemophilia. Now story switches from North America to Sweden. What you can see in this picture is Inga Marie Nelson. Now Inga Marie Nelson in 1950s she started thinking, why should children bleed and develop problems? Why can't I treat the patients before developing bleed? So she started giving cryoprecipitates, etc. to children before they developing bleed. She is called the mother of the treatment called prophylaxis, where you prevent bleeding. Now, again, technology has advanced from 1950s, you reach 1970s and 1980s. Now people have developed this technology, absorbent technology. You can take the cryoprecipitate, and from the cryoprecipitate, you can take, you can lyophilize it, industrial production of factor 8 concentrate, lyophilized concentrate could take place from the cryoprecipitate. So plasma derived factor concentrate started coming in. That was the next level of treatment in hemophilia. Now, once this started happening, patients need not come to the hospital for treatment. Still then, it was blood products. It has to be taken from the blood bank. But now this is in products, and then treatment comes to home. So that was the next big step, is that treatment comes home, and parents and children were taught how to medicate themselves with the plasma derived protein. But again, what happened? There is another problem. Another problem, what was it? In 1980s, as you all know, the HIV pandemic came. So, a lot of people got infected with this plasma derived, who got the plasma derived product got infected with HIV. And there one particularly, interesting story which came in the media was of Ryan White, sweet boy, again in North America, who was denied entry to the school because he had HIV positive and he was hemophiliac. That brought about a lot of uproar, and it also in scientific minds, it sparked the thinking that we should move away from plasma derived factors and try to create something more safe for the patients. Then what happened? The recombinant technology started. So recombinant technology, I think you all would have learned in your basic sciences. So you have, a part of the DNA in a multiplying cell, and you integrate that and produce the protein that you want. Like in a Chinese hamster ovary egg cell, or baby hamster kidney cell, etc., are used to produce multiple proteins. So now moving to the present era, now we have a little bit better understanding of the coagulation cascade, and it's been pioneered by Maureen Hoffman on the cell-based coagulation, which is physiologically more relevant than the cascade model. I'm not going into the details of this, but here it is basically what happens is at the cellular level, you have the coagulation happening. Basically, vascular injury exposes the tissue factor, and then the tissue factor binds to factor 7A in circulation, and there is a kinase complex formed. Then factor 10 is activated, and then the activated factor 10A binds to factor 5A, which is released from collagen-bound platelets, and this activates a small amount of thrombin. Small amount of thrombin is initiated. That's called initiation. And then a small amount of thrombin activates platelets, releasing more factor 5A and exposing the phospholipid surface. And there is more release of factor 8 from contributant factor. And this activates more of factor 8 and activates factor 11. And then there is a propagation where factor 11 is either generated, 11A is either generated by factor 7 tissue factor complex or factor 11A. Factor 9A is generated. So, and factor 9 and 8A forms the kinase complex on the platelet surface. And then the kinase complex, once the kinase complex, this 8 and 9 binding together at the platelet surface is the key thing in the clot formation. That 8 is hemophilia, deficient in hemophilia A, and 9 is deficient in hemophilia B. So that is most important step of the thrombin formation, that is the propagation of the clot. So once the thrombin is formed, as you can see in that initial equation, the fibrinogen is then converted to fibrin, Marrow's equation, which I mentioned earlier. Now, hemophilia, it can happen with the deficiency of 8 or 9. And basically, where we are unable to activate factor 10 and lack of adequate thrombin generation is there. You can see the incidence is very, 1 in 5,000 for A and 1 in 30,000 for females, and it's both are X-linked, and less than 1% is severe, moderate is 1 to 5%, and mild is 5 to 40%. Then you can have carriers of hemophilia gene, especially female, clinical manifestations. Females are carriers usually, and clinical manifestations will be usually similar to men with hemophilia, except that heavy menstrual bleeding will be there, and risk of postpartum hemorrhage will be there in females. So basically, you know about the Lyon's hypothesis. There will be X inactivation, and depending on the X inactivation, you can have a completely asymptomatic carrier or a very symptomatic carrier in the girls with hemophilia. Now, how do you diagnose hemophilia? You can diagnose by family history. 2/3 of patients will have a family history. 1/3 will not have a family history. There will be abnormal bleeding history, and mostly it will be joint bleed, prolonged APTT as described, and then you can check for the low factor 8 or factor 9 activity, and you have to rule out other causes of factor as deficiency. You have 2 types of tests in the lab. One is the clotting assay, which is called the one-stage assay. It's very similar to APTT, and it is measured by serially diluting the plasma that is deficient in the clotting factor of interest. The other thing is by colorimetry, that like chromogenic assay. So I'm not going to the details of all this, But you can have false positive factor deficiencies. Like if the sample is kept in the open for too long, then it may result in because it's a very labile factor, it may evaporate and go, and then so it is it can be false positive. That is a pre-analytic error. Then it can be low in a von Willebrand disease, especially type 2N von Willebrand disease. Acquired hemophilia can be seen in the older age or in postpartum. There also you can have a factor VIII deficiency. Factor IX deficiency can be seen in liver disease, also in vitamin K deficiency. So what is the clinical manifestation of hemophilia? Can present with joint bleed. Main manifestation, 80% of the patients is joint bleed. You can have chronic joint pains and functional limitations. Patient may die due to an intracranial bleed, or it may have cognitive defects. You may have a muscular bleeding, hematuria, or post-surgical bleeding. The management of a bleed, you have to protect, rest the joint, apply ice, compress the injured joint by wrapping it, and elevate the part. You can also, this is called TRICE, and it is slightly modified. Now the rest, you don't have to always rest under the care of a physiatrist. You can try optimally loading the the limb. Once the good hemostasis is achieved. So hemophilia can lead to a lot of joint damage, and that is very deforming. As you can see, so many deformities and can occur due to a recurrent bleed. It's not only the acute bleed, a chronically debilitating disease because of the joint damage. So in general, there are two types of treatment. One is on demand, as and when there is a bleeding, you treat the patient. And the other thing is the prophylaxis. And continuous prophylaxis is there. And you can have a primary prophylaxis before the joint damage. Secondary prophylaxis also before the joint damage, but after 1 or 2 joint bleeds is secondary prophylaxis. Tertiary prophylaxis is after the onset of joint disease. You can also have a targeted prophylaxis, like the patient goes for a surgery or a sport, you can do it at that time. On-demand treatment is considered inferior and prophylaxis is considered superior, especially to prevent bleed and to prevent joint damage. And many studies have regularly proved this. Is one of the studies which I'm just quoting that. In the interest of time, I'm just rushing through a few of these slides, but there are different types where which we can prophylax. High dose prophylaxis is practiced in the Western world. Intermediate dose practiced in some of the countries with a bit of resource constraint. And in countries of low and middle income countries like ours, low dose prophylaxis is practiced. This is as per the latest guidelines of the World Federation of Hemophilia in 2020. And I must mention that till the previous guideline, there was no mention of low dose prophylaxis, but prophylaxis can be also tailored due to pharmacokinetically. There are different machine, programs by which you can actually find out how much factor to give for a patient. Or it can be based on a clinical, you do a clinical judgment and do the prophylaxis. We have been able to do some work in hemophilia at our center and also in Hemophilia Treatment Center, Aluva, under the guidance of Dr. Vijayakumar there. So we have tried doing a low dose prophylaxis, and we can see that the bleed rates, hospitalization rates, and school absenteeism of children really come down, even with the resource constraint setting like ours. It is probably 1/4 of the dose that the resource rich countries using is that we are using, and this we had initially published. Subsequently also we were trying to follow up on our patients, and we have published it again, and consistently the bleed rates, hospitalization rates, and school absenteeism had come down with the low dose prophylaxis for hemophiliacs. Now they were still bleeding, but we want to find out whether the joint bleed should be 0 or whether they can be allowed to bleed further. Ideally 0, but this study actually found out that if the patient bleeds 3 or less than 3, then they may not have a joint bleed. In a year, 3 joint damage. So 3 or less than 3 means they may not have a joint damage. So, we then tried looking at, based on this, at what dose we should use for prophylaxis in our resource constraints. And we found that, if we use it a little bit more than 10 units per kg per dose, which is much lower than what the resource rich countries use, it will be around 40. 40 would be the total dose that they would be using. So at that rate, we could actually bring down the bleed to around 3, which may be actually acceptable in the current setting. So, it is important that we, do something and then document it and publish it, because it may lead to some good things. Here, this has actually led to our state in Kerala. Now they have approved prophylaxis for children under 18 years, and now all children under 18 years in Kerala at least is destined to receive prophylaxis, which is going to be the standard of care in hemophilia. There are newer advances coming. I will just rush through that. You have newer technologies like coagulation, which actually extends the half-life. You can see the standard half-life is small. You get only 2 days worth of factor in a standard half-life product. But if you use an extended half-life product in factor 8, it may last for 3-4 days. Whereas in factor 9, it may be last for about 2 weeks or so. So, extended half-life products is something which is coming up, and that futuristically, I think that will be more available in India. So, there are also other types of treatment which are coming in, like, factor 8 mimics like emicizumab, and then you can have bypassing agents for patients who develop inhibitors like recombinant factor 7 and APCC. One of the important things, the complication I should mention, is the inhibitor development, which is antibody development. You develop an antibody and then the factor becomes ineffective. There can be a low titer of less than 5 Bethesda unit. It is measured using a method called Bethesda assay. It can be low titer or it can be high titer or high responding, more than 5 units. So inhibitor eradication, inhibitor is a major problem in hemophilia care. Your factor will not be effective anymore. So you will have to go for some treatment called an ITI, or immune tolerance induction. You just have to be aware of it. It is giving high dose factor 8 to patients who are not responding to low dose. Regularly, you have to give high dose for months together to eradicate the inhibitor. It is like desensitization. You keep it high dose, give it, and then eradicate it. It's a very cumbersome thing. Sometimes it is very difficult to practice it, but it is an effective treatment for high titer inhibitors. But those who, I said, factor 8 will not be effective for such patients. So for bleeding, so recombinant factor 7 is a bypassing agent, and activated prothrombin complex concentrate, which consists of 2, 7, 9, and 10 factors, also can be used as a bypassing agent for bleeding prevention, treatment of bleeding in that patient. I think you should also know about emicizumab. A couple of minutes on that. It is a bispecific antibody. Actually, it's a very, very important drug. It has revolutionized the treatment of hemophilia. This is what factor 8 does here. It brings together the 9 and 10 and makes the tenase, and with 10 is activated to form the thrombin. Now, instead of 8 is not there. Even if 8 is inhibited or 8 is not there, this will come. This one will bind. It's a bispecific, and one will bind to factor 9 and one will bind to factor 10, and it will, do whatever job the factor 8 is supposed to do. And you can see here that you have many patients who have 0 bleeds, which is not even possible with prophylaxis of CFCs. So as you can see here, here it can be given subcutaneously. So there is no venous access problem also. You can give subcutaneously, and it can have a long half-life. There is no trough levels. It maintains a steady state once in a week, once in 2 weeks, or once in 4 weeks. So that is as good as it can get now. And the bleed rate is very low. And there are also other agents which rebalances hemostasis, like fitusiran, which is a siRNA which targets antithrombin mRNA. Antithrombin is it is an anticoagulant. So you block the anticoagulant and make the system more procoagulant. So in factor 8 deficient, it is more anticoagulant, and you block the anticoagulant and make it rebalance the hemostasis. That is how the concizumab is also acting in a similar way, where it acts against the tissue factor pathway inhibitor, and that also rebalances the hemostasis. So these are exciting new drugs which are going to come in. One word about the gene therapy. Gene therapy is the curative therapy as of now. A lot of noise is happening. A lot of publications have come for both factor 8 and factor 9, both hemophilia A and B, where you use a vector like adeno-associated viral vector and introduce the factor 8 gene into the body, and you maintain good levels, and the patients may get cured for life. So that is very exciting for the future of hemophilia. There are other drugs that we can use supportive like desmopressin and antifibrinolytics like tranexamic acid. Tranexamic acid, of course, it is a little contraindicated in renal bleeding, and it should not be combined with FABA. I think I'll come to the concluding slides. Now, we are living in an era where a lot of new things, exciting things are happening. Hemophilia is a genetic disorder associated with bleeding and musculoskeletal deformities secondary to bleed. It can be effectively diagnosed and treated in the modern era. And as you can see here in this picture, in 1900s, hemophiliac's average age was 13 in the Western world. And in US now, at least, they live up to normal lifespan of a normal individual. In India, it is not yet reached, but I think we should be hopeful that it will be in that way very soon. With that, I thank you again for patient listening, and I thank everybody who's worked behind the welfare of hemophilia patients.
Thank you so much, sir, for this very informative session. Now, I kindly request Dr. Manoj Unni to introduce our next speaker, that is Dr. Revati Raj, and then I want Dr. Jayakumar, sir, to introduce the topic further. Thank you.
Good evening, dear all. At the outset, I would like to thank the organizers of this meeting for your kind invitation to chair this session. As you know, this first is a prestigious program of the undergraduates of Amrita Medical College. So they have been conducting this program for the last 4 years. And today, we have another session, an important session in pediatrics, that is acute lymphatic leukemia. So this is a condition most parents are scared. So in clinical practice, when a child is having fever for more than 7 days, when a child is having severe pallor, when a child is having severe bleeding tendency, we suspect acute leukemia as a possibility. We know very well that fever can be due to a viral infection. At the same time, pallor can be due to iron deficiency anemia. And bleeding tendency may be due to a viral fever or because of eosinophilia or because of ITP. But this condition, we have to consider in all these situations. A lot of advance has taken place in the diagnosis and management of acute lymphoid leukemia, and near survival is possible, almost 100% survival. So many leukemic survivors are married and they have children. To talk about all these advances, we have an eminent speaker, and Dr. Manoj Unni is going to introduce the speaker. I would like to thank once again for your kind invitation. Thank you so much.
Good evening once again. It's a pleasure to introduce Dr. Revati Raj. She's going to be the next speaker for the acute lymphoblastic leukemia. She, just to tell about her, she completed her MBBS from Madras University, completed a post-graduation from Institute of Child Health and Hospital for Children, Madras. She further went to the United Kingdom and did her MRCP in Royal College of Physicians and further FRC Pathology at Royal College of Pathologists, UK. Currently, she is a pediatric hemato-oncologist at Apollo Hospital, Chennai. She leads a very well-known department. It's famous all over India. It is known all over India and even abroad. Welcome, Dr. Raj, for your session, please. Thank you.
Namaste all, and to the organizers of SPASHT and all of the students, the faculty, wish you all a great conference and hope you learn from whatever we are about to share. Thank you so much for this opportunity. If you give me a minute, I will share my screen. Are you able to see my screen? Yes. Shall I proceed? Okay, thank you. So the first thing I want to say is hematology is a topic that a lot of the medical students don't choose as a career, but I want to make sure that we inspire at least a few of you to think about this for the future. I think it's one of the few specialties where you have a good mixture of lab work and clinical work, and you feel a little bit like Sherlock Holmes. So this is something, if people are curious and you want to know how to make a diagnosis, also balance with clinical work, you have acute work, acutely ill patients and chronically ill patients, and there are a lot of exciting advances in this field. So this is something I would strongly recommend that you think about for the future. Of course, work-life balance is important, and this is how you decide to lead your life. It's a good specialty for you to consider for the future. And when Dr. Neeraj had called and said to talk about childhood leukemia, I wanted to say that the story of the journey is as important as the destination as to where we are. So I'm going to spend a lot more time on the journey than on the destination. So acute lymphoblastic leukemia, I don't know how many of you had a chance to read Siddhartha Mukherjee's Emperor of All Maladies. I really love the part where he talks about Sidney Farber and how he gave little doses of chemotherapy to children with cancer and how they survived. And that is what you see in the first column, where about 10 to 15% of the children survived. And then a lot of them, the disease came back. And then they discovered that it was all coming back in the nervous system. The cells had the tendency to melt with chemotherapy, but came back somewhere else in the body, which were called sanctuary sites. And you can see there's a big leap in the 1960s and 70s when they introduced cranial radiotherapy in the outcomes. And then advances have been made in how we treat these children. So I want to spend about 10-15 minutes talking about this journey, about how we've learned to treat this really challenging disorder. Childhood cancer is a condition where you see it's totally different to adult cancers. So when you do something very fast, or when you are very tired and you do something, you're bound to make mistakes. So this is what happens in cells. Childhood cancer is a disorder where the fast growing cells of the body get into trouble, which is namely the blood cells and the brain cells. So if you see, leukemia and brain tumors are the commonest malignancies in children. And as we grow older, you get the lung, colon and breast and cervical cancer, head and neck malignancies, which you don't see in children at all. So the first question parents ask us is, why did my child get cancer? So I've done all the right things. How did this happen? And we tell them that this is all to do with the genes. And this really freaks out parents. But what we need to understand is that there are two types of genes: somatic genes, which control the cell cycle in each individual cell, and the germline genes, which come from the egg and sperm, and those that we inherit from the parents. So these somatic genes drive the cells like we drive a car. One pack of genes says you have to divide. Another pack of genes says, okay, it's enough, you can stop dividing. And when there is an imbalance, when the driving genes are overworking or the inhibitor genes are underworking, you can get uncontrolled cell proliferation, which we call cancer. So genes in cancer, I said only 5% of childhood cancers are inherited, and retinoblastoma or eye cancers are very, the index case of inherited genes. So if the mother had retinoblastoma, the child has a very high chance of getting retinoblastoma. So in leukemia, the prodigal cell, the cell that goes which is at fault, is the lymphoid progenitor cell. So in the bone marrow, we have the blood forming stem cell, which makes white blood cells, which are myeloid and lymphoid. And when these lymphoid cells grow in an unlimited manner, then we get leukemia or acute lymphoblastic leukemia. It's a very great mimicker, and the children can present with prolonged fever. They can just look pale, and someone does a blood test and find out that they have a blood cancer, or they can present dramatically with bleed, nose bleeds, mouth bleeds, or just a lymph gland swelling, abdominal distension, severe bone pain. People think that the child has arthritis, or rarely a testicular mass or CNS symptoms. This is where we've made huge advances in diagnosis. We can look at an individual cell with a technology called flow cytometry. So if you all go to the Olympics, you know that the flag bearer tells where that particular band of athletes come from, which country. So each cell carries a cluster differentiating antigen. So CD10 is the commonest ALL antigen. So if the cell carries CD10, the flow cytometry can pick it up because we add a CD10 antibody. If the cell carries CD3, then it picks up that it carries a CD3 antibody. So this has made a huge difference, because when we started hematology, we were only looking down the slide and saying you have ALL. But now we can look at millions of cells in one particular drop of bone marrow and say that these are the antigens that the cell is carrying, and it helps us in diagnosis and in also planning therapy. The other thing we realized is that the leukemic cells have alterations in their genes. This is to do with the leukemic cell. And you see this classic test, which is called a FISH test. The chromosomes are painted with the 9th chromosome painted in red and the 22nd chromosome painted in green. So normally they're supposed to be away from each other. You have 2 9 chromosomes and 2 22nd chromosomes. But sometimes when they have translocations, when one bit is stuck to another, both the genes, the pink and the green, are stuck together. And because of this altered genes, there is more and more drive for these cells to grow. So the signals are all pro-growth. And you can see that the outcomes vary in children who carry these genes. Some of them are really poor. So it's the same ALL, but based on the genes, we can say some are good prognosis and some are poor prognosis. So this is the basis of risk stratification. We don't give all the children the same treatment. We look at what markers they carry, and based on what markers they carry, we start the treatment, giving some of them lower doses of treatment and higher doses of treatment to the others whom we think are high risk. This is a remarkable achievement in my lifetime. It's called measurable residual disease. So the flow cytometry can look at 100,000 cells. And in 1 in 100,000 cell, it can pick up a leukemic cell. So for example, the top right-hand corner, the leukemic cells on day 1 carry CD3. We've given 28 days treatment. So look at the same top right-hand corner on day 28. It's all gone like magic. So the children that have less than 1 in 100,000 cells of leukemic cells, or 1 in 10,000 leukemic cells, they do better compared to those who have remaining cells. This helps us because the ones that are in the bottom, like how you have extra tuition for the weaker children in the class, the ones that are right at the bottom, we add extra chemotherapy right at the start so that the disease does not come back later. And overall, we are able to cure most of the children we treat. Next generation sequencing can look at the DNA level. What are the bad cells? What DNA do they carry? And this has helped us pick up the leukemic cells even better and delineate how we have to risk stratify. So we now have 4 groups. the low risk, the standard risk, the high risk, and the very high risk. Low risk, we give such minimum doses of chemotherapy that they don't have side effects. The very high risk, we throw all we have at them, including changing their bone marrow. The standard and high risk get chemotherapy. Also, we realize the cells go down with chemotherapy, but again have a tendency to come back. So this is where leukemia treatment is prolonged. So it's not short, sharp chemotherapy, but for a prolonged period, 2 to 3 years, as the leukemic cells are thinking of coming back, we do intensive phases in between so that they don't think of coming back. So there are several phases in which we treat. And you can see that over the last 50 years, we've been using the same medications: prednisolone, vincristine, donomycin, asparaginase, cyclophosphamide, cytarabine, 6-mercaptopurine, and methotrexate. The drugs haven't changed, but the outcomes have changed from 10% to 90%. So how did we do this? This is the most interesting part of the journey. The first thing is the children present to us in a dramatic manner. They need blood, they need platelets. So there have been several blood donors who've helped us fight leukemia, not just the physicians and nurses. Also, there are drugs that help dissolve uric acid and other byproducts of the cancer cells, which can cause kidney failure as the child presents initially with a heavy tumor burden. Doing repeated injections in children, very, very difficult. So we have better venous access. So you can imagine the pain of parents when they have to have repeated blood tests. So we have venous access devices called PICC lines and chemo ports, which have made a world of difference. We've formed little groups to educate our nurses and our team and have got smarter at looking at multi-drug resistant bacteria and how we can prevent the spread and treat them, because chemotherapy means low immunity means infections. So infection prevention is the main key to supportive care. I also mentioned that the leukemic cells can cross the blood-brain barrier, but our chemotherapy doesn't. So these are the sanctuary sites. So how do we protect the CNS? Before, we used to give them radiotherapy, and then we found that there are a lot of late side effects. Some of them have needed special education. They've had thyroid problems, pituitary problems. So we are now trying to avoid prophylactic cranial radiotherapy, but we are able to deliver chemotherapy into the CSF, which is called intrathecal chemotherapy. Major advances have been made in drug delivery. Dr. Neeraj had mentioned this process called pegylation. PEG stands for polyethylene glycol. So you just tag the drug to polyethylene glycol, a drug which has 48 hours lifespan becomes 2 weeks. So this is a very important drug, which is the backbone of our chemotherapy, and a simple innovation, tagging the drug to PEG, makes its half-life 2 weeks. So the drug works by depleting the cancer cell of a very important amino acid called asparagine. So without asparagine, the cell can't live. So if you do a prolonged depletion, then the work of the same drug is so much better than up, down, where we had to give every 48 hours injection before. We also realized that each of us handle the chemotherapy drugs differently. Some of us are born with enzymes at very high levels. So as the chemotherapy drugs enter our system, our body chomps it up, not enough time for it to work. Some of us don't have enough levels of enzyme to digest the chemotherapy, and we suffer the toxicity. So we are now tailoring cure versus adverse events by looking at pharmacogenetics. But the main problem in our country has been abandonment. If the treatment is for 2 years, 3 years, with financially borderline families, they feel that they can't continue treatment because it means repeated hospital visits. So much of goodwill has happened in the world of pediatric cancer, and so many NGOs have come forward to give them chemotherapy drugs, provide financial assistance, and home away from home for parents to stay when they have to come to the cities and have the treatment. How are we faring in India compared to the rest of the world? Our outcomes have been in the 60 to 70% range rather than the 85 to 90% range. We know that the drugs are not very expensive, but the supportive care and the stay is where we have to address to make our work better. So we've now begun to work together. Worldwide, childhood cancers are all forming groups to work together so that we can learn from each other. So we have the Children's Oncology Group, the UK MRC group, the BFM group, and in India, we have the ICICL group, which will spearhead, and hopefully things will be better over the next decade for our children. So in the West, they've reached a phase where only 5 to 10% of these children are not responding to treatment. So what can they do better? So again, over the last 3 to 4 years, new drugs have come for childhood cancer, which is a promising beginning. And this is bilateral thinking. So instead of giving chemotherapy that would destroy all of the rapidly growing cells, why not target only the cancer cell? So I was telling you the story of BCR-ABL. So the Philadelphia chromosome positive leukemia, we now have a drug which just blocks the BCR-ABL protein. So it only targets the cancer cell. So you can see on this graph that historical control, the outcomes for the Philadelphia chromosome positive ALL, those children that carried this gene, it was so poor. But when we've added this imatinib, dasatinib, these are the tyrosine kinase blocker agents, the outcomes are so much better, and the chemotherapy and transplant arms have come to close to 70 to 80%, which is amazing. The other advance we have is again through lateral thinking. How can we wake up the immune system? How can we make the immune system look at the cancer cell and eliminate it? So these are called BITE therapy. So this is bispecific T cell engager. T lymphocytes carry CD3 marker and the cancer cells carry CD19 marker. So they have tagged the CD19 antibody and the CD3 antibody so that it will attract and engage both the cancer cell and the T lymphocytes, which is our immune surveillance cell. And the immune system itself is called upon to destroy the cancer cell. This is amazing because those children that were refractory to chemotherapy, we are now able to offer blinatumomab. But the king of the castle now is CAR T cells. And this is technology that we are trying to bring to India as well. We've already started in Mumbai along with the IIT Mumbai and Tata team. Hopefully there will be more to come. But CAR T cells are the way to go for cancer, leukemic children who are refractory to treatment. And what it involves is taking the child's own lymphocytes, teaching it in the lab to recognize the cancer cells and putting it back into the child. And this amazing technology has helped remove all of the cancer cells in very difficult patients. This is our data over the last 15 to 20 years. We're seeing about 75 to 80% long-term surviving children. And we have so many of our patients who've now become doctors, engineers, and who are giving back to the society. So 3 out of 4 children can actually be cured. So this is something that we have to remember, that it's not abysmal. So if you see a family, don't give them a very sad picture, give them the message of hope. We need to risk stratify, individualize treatment, learn to work from each other. Every little drop in that treatment makes a difference. So we have to make sure the whole chain works correctly. Maybe the future would be targeted therapy, but we have to begin with intact survival, reduce the side effects of our treatment, and never give up on a child, and whatever it takes to prevent abandonment for the family from giving up, we should do our best to help. And to the students here, I'm going to make an appeal to register as a blood donor today, because donors are the lifeline for these children. And hopefully, you guys are the ones who will continue lateral thinking and pave the way for innovative treatments of the future. Thank you very much. I can't do what I do without my whole team of people who help, and fighting cancer is team effort. and hopefully the future is bright. Thank you.
Thank you so much, ma'am, for this very interesting session. And now we have received a couple of questions which will be addressed by our moderators.
Thank you, Dr. Revati Rajan, for the excellent presentation. So there are a few questions in the audience from the students. The first question is, what are the three most important prognostic factors in determining long-term survival for children with ALL?
Okay, so that's a good question. As I said, on day one, we have some risk stratification. What is the child's age? Is it less than 10, more than 10? Do they have B cell type or T cell type? Is their count less than 50,000, more than 50,000? But the most important determinant is how do they respond to treatment? So minimal residual disease or measurable residual disease on day 28, we give them the treatment, look at how they've responded on the 28th day. That is a very important indicator whether the child is going to be in the curative group or not, because if we can't eliminate the disease, it's going to be a problem. And the second one is cytogenetics. There are some adverse cytogenetics and some good cytogenetics, and this again will tell us how we risk stratify. And third is that we may make big plans, but the child should be able to cope with all the treatment without all of the infections around us. So the whole plan is based on how they respond to the treatment without the therapy related toxicity. For example, some of the drugs we use could have adverse effects. Because of that, the treatment gets delayed. So we should deliver the treatment without any gaps, and we should risk stratify correctly based on cytogenetics and their response to the first induction treatment. This is the principle of any leukemia treatment.
Thank you, ma'am. So next question from the audience is, can a pediatric patient with ALL conceive a child in future?
Absolutely. So that's what we meant about intact survival. And in every cancer, we say, when do we call them in remission? When do we use the word cure? So if you take, for example, Burkitt's lymphoma, very highly aggressive type of lymphoma. So they finish chemotherapy and they're 9 months of chemotherapy, then we can say that the disease is not going to come back. So for example, in AML, from the day they finish treatment for 2 years, we call them in remission. After 2 years, it's unlikely that the disease will come back. So like that for ALL, when they are 5 years of chemotherapy in acute lymphoblastic leukemia, you can usually say that it's unlikely that the disease will come back at 5 years. And all of the drugs we use, we try to avoid those that have an impact on fertility in growing children. So as we already said, we are aiming for intact survival.
Thank you, ma'am. Next, Dr. Neeraj. I'm sure after Dr. Revati ma'am and Dr. Neeraj talk, a lot of students will be interested in hematology. So for the next set of questions to Dr. Neeraj is, there are 4 questions. I will just tell one by one. Dr. Neeraj can answer it later. First, the factor 8 assay gives a false positive and we start treatment for hemophilia. Will it cause complications due to excessive clots? The second question is, can hemophilia patients take COVID vaccine? The third is, are there any congenital abnormalities in babies born with hemophilia? And fourth, can hemophilia be diagnosed prenatally? Over to you, Dr. Neeraj.
Okay. Thanks for those questions. First question is, if the factor VIII assay gives a false positive, and we can start treatment for hemophilia. We start hemophilia treatment. In general, I think we should be cautious about the false positive factor assays. As I mentioned earlier, the factor, if you don't take care of the pre-analytic factors, you may get a falsely low factor because these. Once you collect the sample in the citrate tube, and then you separate the plasma. Then if the test is delayed, it has to be frozen down to -20 degrees immediately. Otherwise, you lose the factor VIII. And if sometimes the tests are performed outsourced to another lab, and the cold chain, which Madam was mentioning in her talk, is applicable here also in the diagnostic testing. So if the cold chain is not maintained of the sample, you may get a falsely negative, falsely low factor VIII levels. And we should be very mindful of that. And so a very elaborate history, you should have a thorough clinical suspicion of what we're doing, what we're suspecting. You should have correlation between APTT and the factor assay. So it is best that we are convinced about the diagnosis before we start treatment. The question is perfect, I think, because the factor VIII levels in high concentration are known to be thrombogenic. So it's very, very good question, I think. And the answer is that, yeah, we should avoid such a situation. Second question is, can hemophilia patients take COVID vaccine? The answer is yes, and there are good guidelines for this, and I think almost all of our hemophilia patients have taken COVID vaccine. In those who are taking prophylaxis, we gently advise them to continue the prophylaxis and take vaccine a couple of 1 or 2 days after the last prophylactic injection has been taken. And we can use a smaller gauge needle and put pressure for about 10 minutes at the site of vaccination. I've not come across anybody who has bled once this precaution has been taken, and they can continue their prophylactic second dose after the vaccination. In general, though we do not try to combine the vaccine and the prophylaxis on the same day, because sometimes some of these vaccines may be inhibitogenic, inhibitor response may happen. But yes, they can take. Are there any congenital anomalies, other congenital anomalies in patients born with strictly with hemophilia A and hemophilia B? It is only the factor deficiencies that are seen in those babies, and they are absolutely normal in all other systems. I am sorry I could not address this in my talk. The last question is also very important. Can hemophilia be diagnosed prenatally? I had got a scolding from my wife last time also when I spoke about hemophilia. She says, I don't speak about prenatal diagnosis. Indeed, we should emphasize on prenatal diagnosis and carrier detection. Because there are different molecular mutations responsible for the factor deficiencies, and these can be found out either by polymerase chain reactions or sequencing, Sanger sequencing, or next generation sequencing. So once the index case, the boy with the hemophilia should be diagnosed first, and then the sister may be a carrier. Then you do a carrier detection of the same mutation in the sister, and then when the sister gets pregnant, you can when she conceives during the first trimester, you can meet the geneticist, and the prenatal diagnosis can be made through amniocentesis or chorionic villi biopsy. You could detect the mutation in the child. Yes, prenatal diagnosis can be done in hemophilia. Although sometimes we have seen that in the era of current treatment, the previous question is that they may be able to lead a normal lives in many cases. Prenatal diagnosis certainly can be done.
Thank you so much, sir. Now, I would like to extend my sincere gratitude to the chairpersons for today's session. It is Dr. Manoj Unni, Dr. M.G.K. Pillai, sir, Dr. Jayakumar, and our eminent speakers, Dr. Neeraj Siddharthan and Dr. Revati Raj, for sparing some time from their very hectic schedules for making this session possible. It was a great honor for us. Thank you. We'll be starting our panel discussion shortly. We'll be taking a 5-minute break. Thank you. Good evening. It is a great pleasure for us to have the opportunity to host the panel discussion on therapeutics in hematology. Today's moderators are Dr. Neeraj Siddharthan. We have the honor of having him also as a moderator for this session. Dr. Princy Louis Pilati. She completed her MBBS from Goa Medical College, Bombay University, completed post-graduation from Goa Medical College, Goa University, and currently she is the HOD and professor in the Department of Pharmacology at Amrita Institute of Medical Sciences, Kochi. Dr. Karthika KV, she did her MBBS from IRT Perundurai Medical College and Research Center, Perundurai. Completed her post-graduation in pathology from Government Medical College, Kozhikode, and DNB Pathology and DM Hematopathology from All India Institute of Medical Sciences. She was a clinical assistant professor of clinical hematology at Amrita Institute of Medical Sciences, Kochi. We will begin this session with a student's perspective for a specific topic, followed by an in-depth understanding of the same by our esteemed panelists. So today's session has been divided into 3 parts. The first part being on bone marrow transplantation, the second part being on the CAR-T cell therapy, and the third part being on CML. Now, I kindly request Dr. Neeraj Siddharthan to take over.
Thank you, Arunima, and good evening again. It's my pleasure now to introduce the panel discussion and our eminent panelist, Professor Dr. Biju George. Professor Biju George has done his graduation from Madras University and in CMC Vellore and done his internal medicine MD and DM in clinical hematology and CMC Vellore and MGR Medical University. And he has taught higher studies in Australia, and he specializes in a lot of areas in hematology, including bone marrow failures and haploidentical transplant. Has done some pioneering work in the country, and he's currently professor and head at Department of Hematology at Christian Medical College, Vellore. And it's my pleasure to introduce you, Dr. Biju, to all of you today, and he'll be speaking on bone marrow transplantation as a panelist. So how, sir, with your kind permission, let me ask, we have designed it in such a way that the student, one of the students is going to present a couple of slides on bone marrow transplant as per their understanding. And we will have MBBS student, Ms. Anju Anand, presenting the slides. Over to you, Anju.
So, good evening, everyone. My name is Anju Anand. I am a third-year MBBS student studying here in Amrita Institute of Medical Science, and I am here to give you my perspective on HLA and bone marrow transplantation. First of all, I would like to thank the first organizing team for giving me the opportunity to present here in this conference, and I would also like to thank Hematology Department for helping me prepare for this. So, HLA and bone marrow transplantation is something that most of us have already studied in physiology, pathology, and microbiology. And this will be a very basic presentation on the topic. So HLA stands for human leukocyte antigen. There are mainly two classes, 1 and 2, and recently class 3 was also discovered. And molecular HLA typing is routinely performed in unrelated donor hematopoietic stem cell transplantation. And HLA also has an association with autoimmune diseases. For example, HLA-B27 have a strong association with spondyloarthritis. Next, we look at the gene coding. The gene coding for this antigen is located on the short arm of chromosome 6. HLA was first identified using alloantibodies against the leukocyte. So, like these alloantibodies would form a complex with the HLA molecule on the leukocyte, and that is how they were discovered. The primary function of HLA is to present foreign antibodies, that is, both endogenous and exogenous antibodies to elicit T cell responses. So HLA typing is done for matching donors and patients for bone marrow transplant. And this is to reduce the risk of graft versus host disease. So to put it very simply, body uses HLA to recognize which cells belong in the body and which cells do not. So, and graft versus host disease is a condition where the donor cells attack the recipient. And to reduce the risk of that, we do HLA typing. And that is a very basic introduction to the topic. And I hope everyone is as excited as I am for the upcoming session. We have with us these amazing people here who are all experts on the subject and who will definitely satisfy our curiosity of all the attendees. And it is because of this curiosity that we are able to conduct these sessions, because a lot of people are interested to attend. And once again, thank you for this opportunity, and I hope you all have a great experience.
Thank you, Anju. That was a very nice introduction to the topic. Viju, sir,
Yeah.
can we start, sir? Thank you very much for joining and taking your time off your very busy schedule.
Can I just share my screen, please?
Yes, sir.
Okay. Yeah, let's start, Neeraj.
Yes, sir. Sir, I think we have a question. I think the students have given a few questions for me to ask you. The first one is they want to know what are the common diseases cured by bone marrow transplantation and various types of bone marrow BMTs that are done.
Yeah. So I think when we look in principle at the types of bone marrow transplant, there are officially two types. One, what is called as an autologous transplant, and one is an allogenic transplant. The difference is that auto means self. So the patient himself is the donor, while in allogenic, you have a separate donor and a separate patient. So I've just put the schemata of what happens. So on the left side, you have a patient who needs a transplant. He receives chemotherapy or radiation, a combination, depending upon what disease they are suffering from. And then the stem cells that you need, you get it from a separate person who's a donor, who has to be HLA matched. And then you infuse it after the chemotherapy is done. And if everything goes well, this patient is cured. Now, when we look at an autologous transplant, on the other hand, the patient acts as the own donor. So the first step in this process is to collect the stem cells from the patient himself and preserve it. Once that is done, you give chemotherapy, and the same stem cells that are already collected, you give it back and infuse it to the patient, and things go well, patients are cured. Now, when we look at the diseases, we need to remember that the hematopoietic stem cell, which is actually what is we use for the transplant, can form into the myeloid progenitor cells and then form your platelets, your neutrophils, monocytes, red cells, and of course your lymphoid compartment, both the B and T cells. So any of these diseases, whether it be genetic or an acquired disease, can potentially be cured with the bone marrow transplant. So if you look at the common diseases which get cured under autologous transplant, you have multiple myeloma, you have Hodgkin's and non-Hodgkin's lymphomas, you have acute promyelocytic leukemia, you have the other AMLs, and then other diseases such as autoimmune disorders and neuroblastomas. While on the allogeneic transplant side, you have leukemia, you have aplastic anemia, you have genetic disorders like thalassemia, immune deficiencies, metabolic disorders, myelodysplastic syndromes, and myeloproliferative neoplasms. Now, this is just our own data from our own center looking at allogeneic transplant. And for us, the most largest group would be thalassemia major, followed by acute myeloid leukemia, followed by aplastic anemia. And that is essentially related to the kind of diseases that we see within the country. The ratio may vary depending upon each individual center, but this would be the three common diseases for which we would transplant. But if you look right at the bottom, rarer diseases such as severe combined immunodeficiency, HLH, Wiskott-Aldrich syndrome, osteopetrosis, Gaucher's, adrenoleukodystrophy. These are also diseases that can be cured with the bone marrow transplant. Over to you, Neeraj.
Thank you, sir. That was a fantastic overview of that BMT. The next question that the students have asked you is they want to know how the bone marrow transplant originated.
Yeah, and it's very fascinating that the results, bone marrow transplant was a response to a clinical need. And the clinical need were actually related to the Hiroshima and Nagasaki explosions, which happened at the end of the Second World War. A lot of people died in the bombings, but many survived. And those who survived, the problem that occurred was many developed either bone marrow failure or they developed leukemia. So they were looking to see how they could rescue people and importantly soldiers who could be exposed to lethal amounts of radiation. And so they went back to experiments within the lab to see how they could help. And this is actually some of the pioneering experiments by Jacobson in 1949, where they took mice, exposed them to large amounts of radiation. The ones which had radiation alone died, but if they either shielded the hind limb with lead or following the radiation, they managed to inject spleen cells, they found that they were protected and did not die. Subsequently, they looked at intravenous infusion of these cells to protect from radiation-induced injury. And that is how actually the first bone marrow transplant started about 6-7 years after that. And this was the first publication in 1957 by Donald Thomas, where they talked about using human bone marrow cells as intravenous infusion in patients receiving radiation or chemotherapy. But we should remember that always the things that you start with may not be successful. And so if you look at a publication in 1970, where they looked at about 200 patients who were transplanted during that period, this was either aplastic anemia or patients with advanced hematological malignancies or immunodeficiency, all 200 died. So there was not even one patient who was alive. But they realized there were some things that were common. One, a lot of them died due to graft failure. That means they just did not accept the donor cells. Or two was that they developed graft versus host disease, which means that the donor cells were overactive within the body, and that led to failure of the body and the body died. And the third, of course, was infection. And that is how people actually, if you look, it is beautiful to look at history that after this happened, a lot of transplant potential centers actually died down because everybody thought transplant will not work. Subsequently, people went on to doing more work in the lab to try and identify why did people fail this transplant, and that is how they came forward to learning what is the importance of HLA. Over to you, Neeraj.
Yes, sir. I think you've covered a part of my next question. I think one of the questions was, why did the BMT fail initially? So
I think one of the important things was when they looked at the first studies, they looked at mice experiments, and inbred mice, even if they were HLA disparate, actually would show good results. And at that time, the major histocompatibility complex was just being discovered. People did not have much of an idea about the immunology of bone marrow transplantation and the lack of understanding of the HLA. I think importantly, along with that, people did not have a good understanding of conditioning regimens and the fact that you needed to prepare the bone marrow to allow these donor cells to come in and go into the marrow. And the third was, there was poor understanding of the fact that despite having a treatment or despite having a match, you still could get graft versus host disease, and people did not realize that you still needed to give some medicines to prevent graft versus host disease from occurring. So if you actually look over a period of time about discoveries which led to things improving, like I mentioned in this period here, where was everyone died. Then they started discovering HLA, the need for HLA, and subsequently the need for conditioning and graft versus host disease prophylaxis with medicines. And what is important is the contribution of a person called as Paul Terasaki, who was the person who first started HLA. And this, as was mentioned, initially started with just serological typing. That means you took the blood, you took the leukocytes, you cross-match with an antibody, and if there was an antigen and an antibody, they react, then the cells would pick up the dye and you look at positive and negative. Now that was all right when we were doing matching between siblings. When it came to looking at unrelated donor matching and beyond that, people started looking at high resolution typing and sequence-based typing to identify the HLA better. Once we understood HLA and the need for HLA, subsequently you started identifying donors who would be matched and taking them up for transplant. And that is where things started becoming better. And so this was one of the publications in 1977 by Donald Thomas, where they actually looked at patients who were HLA matched. And there they found that out of the 100 patients, 94 actually engrafted, and finally about 13 to 20% were alive. A lot of them still died because of disease. But this seminal contribution to transplantation actually led to him getting the Nobel Prize for Medicine in 1990 for his work on bone marrow transplantation. Now, in a monozygotic twin, what you would have is identical HLA. So because that is why if you took from a monozygotic twin, it is unlikely that the cells would be rejected by the body, and so graft failure did not occur. Over to you, Neeraj.
Thank you, sir. I think it's a very fascinating concept that grafts survive initially only in the monozygotic twins, and then HLA was discovered, and then that made life easier for patients getting transplanted. So the next question is about the HLA match itself. Now, you said about HLA match, sir. So, what are the chances of finding an HLA match donor? Either you mentioned about in the family and also outside the family. So, what are the chances of a patient finding a donor?
So normally, if we have a patient who needs a bone marrow transplant, the first step would be to look for an HLA. Now, all of us would get half of the HLA. So as was mentioned, the HLA is through chromosome 6. You have class 1, which looks at HLA A and B, and class 2, which looks at DR. Now, each child will get one A, one B, and one DR from one parent, and the other A, B, and DR from the other parent. So in general, you even depending upon the number of siblings, you have about a 25 to 30% of patients will find a donor within the family. This means that if you have 100 patients who need a transplant, only about 30 will find a donor within the family. So what do we do for the rest whom we do not find a donor? And that is where this worldwide registries have come. Now, these are bone marrow registries where they would invite people who are voluntary donors to give a blood sample or a buccal swab sample. And then you do HLA typing, and these results are stored on computers. Now, if you have a patient who needs a transplant, you can send the HLA typing report of your patient to these registries and search for identical donors within these registries. Now, the common registries that use is the National Marrow Donor Program in the US, which covers also a lot of additional registries. We have the DKMS registry in Germany. We have the Australian Bone Marrow Donor Program, the Canadian, and the programs which are there by the Anthony Nolan Trust. And in India, you have mainly the Datri registry in Chennai, MDRI in Bombay, and there are others that are coming up. You can search within them. Now, what is your chance that you will find a donor within these registries? Now, this was a study done by our HLA lab a few years back, which is actually published in Lancet Hematology, where they showed that depending upon the size of the registry, you had between a 30 to 40% chance of finding a donor. So the larger the donor registry size, the greater chance you will find a donor. And that is why, along with Revati's appeal about being a blood donor, all who are eligible should also register to be a bone marrow donor, because then you are also being useful to the patients who need a bone marrow transplant. Neeraj, you are muted. Sorry, Neeraj, I can't hear you, although you're unmuted.
Okay. Can you hear me, sir?
Yeah, now I can hear you. Yes, Neeraj.
Sorry for the interruptions. So I think they have set some standards already. One of the students had already volunteered as a donor. She is now an alumni. She donated to a patient with thalassemia and unrelated donor. So the patient had undergone transplant in Bangalore, I think, from a Sri Lankan national.
Oh, fantastic. It's lovely to hear that. It's really lovely to hear that.
Yeah, so Dr. Kanmani now, she's now in pursuing her higher studies in pediatric hemato-oncology in UK.
Oh, okay.
So then, thank you. The other thing, I think it will be your topic. Can you transplant a patient without a full HLA match? You are the pioneer in that.
So if you look at the data that is available, we had said 20 to 30% will find a donor within the family. Another 20 to 30% will find a donor in an unrelated registry, but we still, that means have 40 to 50% of patients who do not find a donor in either of them, fully matched. And so people have looked at advances in terms of making sure that whether what we can do. And now advances in medical science have shown that you can transplant across HLA barriers and only half a match is required, which means that potentially for a patient, either your parents or your siblings or your children or somebody in the extended family will be half matched with you. So 95 to 98% of patients should be able to find a half match donor somewhere within the family who could act potentially as a donor. But what are the problems when we do a half match? And I think that has got to do with the fact that when we look at the full HLA, the HLA protects cell from foreign. So because it protects cell from foreign, it can cause higher incidence of graft failure, because when you are HLA matched, your body can recognize the donor cells as foreign and so reject the cells. Or when the cells come in your body will be attacked by the donor lymphocytes and it can lead to graft versus host disease. Now, a lot of it is mediated by the T cells, which help in the GVHD, the CD3 lymphocytes. And what is important to prevent graft failure is the CD34 cells. So always the question is, how can we increase stem cells and reduce the CD3 to ensure that you get good engraftment without increasing graft versus host disease? So work has gone along the way for a number of years, initially with machines. So you take a harvest product, you add antibodies to it, where you could either select out the CD34 positive stem cells, or you could remove out the CD3 positive T cells so that you get a specific depletion, and you could then transplant with those cells. They are good, but they are very costly. And what is now coming over the world is the use of a drug called as cyclophosphamide after transplantation, because cyclophosphamide acts on the activated T cells and not on the memory T cells. And that is because of a drug called as aldehyde dehydrogenase, which is high in them. So because of that, the post-transplant cyclophosphamide can reduce GVHD and help in reducing the incidence of graft versus host disease. And that is what is sort of now pioneered the use of haploidentical transplants across the world. And data from many centers around the world seem to suggest that the outcomes of a haploidentical transplant are slowly reaching similar to the outcomes of either if you had a sibling who's matched or an unrelated donor who's completely matched with you. Yes, Neeraj.
Yeah. Fantastic, sir. That innovations have always had to be reaching all the patients at lower cost, and in that sense, this innovation of the post-transplant cyclophosphamide, where you're able to do a transplant across every patient who needs it without increasing the cost, is indeed a revolutionary change in the treatment. What other future? My final question to you, sir, is there any other future treatments coming up associated with bone marrow transplants?
So I think there are lots of treatments, but I have picked up 3 or 4 which I think is useful for us in an Indian context, because ultimately what we have to do is to make transplant relevant for a larger number of patients within the country. So I think the most important concept is what I've put in the center, that we have to try and make transplants safer and better. Now, to do that, what are the problems that we face in routine clinical practice now? We see a lot of infections, viral, bacterial, and fungal. Some of it is treated with medicines, but medicines which we use to treat also have their own side effects. So can we do anything beyond that? 2 is always the problem of graft versus host disease. There is a certain level up to which you can do with medicines. Can you do anything beyond that to help improve graft versus host disease? Third is the drugs that we use to treat or prepare the bone marrow, what are called as conditioning regimens. Each of them have their own toxicity. Can we try and reduce the toxicity while improving the quality of the treatment given to try and prevent relapse of the disease? So towards this, I would just look at 4 different treatment options. One is the use of cellular therapy. Now, we know that the immune reconstitution within the body after a transplant takes a longer period of time, and that is why you have a high incidence of viral infections. So people are now looking to see, can we take donor cells? Can we collect the T cells? Can we make it specific against, say, CMV or BK or adenovirus? And can we safely infuse it back into the patient to treat viral infections or even prevent viral infections from occurring following a bone marrow transplant? Second, people are again looking at a similar format to see, can we take donor cells? Can we sort of take tumor antigens, expose it to that? So these becomes lymphocytes which are active against tumor cells, and then you can infuse it, expand it, and infuse it back into the patient to treat cancer or prevent cancer from relapsing after a bone marrow transplant. The third is with regard to toxicity. And so we use, in a number of patients, we use radiation. And unfortunately, what happens is when we give radiation to the bone marrow, we also deliver radiation at high levels to other organs like the liver, like the gut, like the lungs, which limits the amount that you can go up. Now, innovative techniques have come up, what is called as total marrow lymphoid irradiation, where you can deliver very high levels to the marrow, and you can ensure that the levels which go through the different organs have actually come down. And we have done so far about 35 patients using TMLI, and right now our 1-year survival using TMLI is sitting at about 90%, while when we used chemotherapy, we are sitting at about 50%. So this is something which can be done, and they use just a tomotherapy, which is used by a lot of radiation colleagues for other diseases around the country, which is easily available. And the last is to look at extracorporeal photopheresis. This is a method by which you take the T cells from the patient who are active, you neutralize them, and you infuse it back into the patient. The present methodology that we have now uses a separate machine, which is very costly, and we have to try and look and see how we can use this as both treatment as well as prophylaxis to try and reduce graft versus host disease from occurring. These are probably the 4 things which I think will help in revolutionizing treatment and help them making transplants both safer and better in the future.
Thank you. Thank you very much, sir. I think Anju would have satisfied her curiosity, which she mentioned in the beginning, more than from your talk and the discussion here, sir. So thank you very much. Please do stay on. There may be some more questions from the students who are attending the session after, but we are now proceeding with the second panel.
Sure.
Panel. Thank you, sir.
I would like to thank Dr. Biju George, Dr. Neeraj Siddharthan, and Anju Anand for their valuable contribution towards this panel discussion. Now, I kindly request Dr. Karthika to take over.
Thank you. Am I audible?
Yes, ma'am.
Thank you. So till now, it was a really refreshing session from the hematology point of view for our undergraduate students. And I'm sure it's going to be the same till the end. So it's an honor and a pleasure to invite the next panelist for the day, Dr. Naveen Kadri. I take the honor of introducing him. Sir had completed his MBBS from Kolkata, and then he did his MD Medicine from PGI Chandigarh, followed by his DM in Medical Oncology from the prestigious All India Institute for Medical Sciences, New Delhi. Sir is currently working as the Professor of Medical Oncology and Deputy Director at ATREC, the Advanced Center for Treatment, Research and Education in Cancer, Tata Memorial Center, Mumbai, where most of the pioneering studies in bone marrow transplant are happening. So before we move on to the students' perspective, a short introduction on what we are going to discuss today. CAR T cell therapy, or chimeric antigen receptor T cell therapy, also known as the living drug. So in existing therapies where bone marrow malignancies, hematological malignancies are treated with chemotherapy, which annihilate the immune system, CAR T holds a promising avenue for treatment where we facilitate the body's own cells and modify them in a way to attack the tumor cells. So this path-breaking delivery holds promise for many of these patients and is the future for treatment of many hematological and solid malignancies. And in order to throw light on this fascinating technology, I request Ms. Aditi Arora to present her perspective on what their idea on these T cells are and how these T cells are actually modified, that we will have the specialist speaking on. Over to you, Ms. Aditi.
Good evening, everyone. I'm Aditi Arora, presenting a brief talk as an introduction to this innovative strategy, CAR T cell therapy. Yeah. We have our own soldiers. Immunity is the resistance or defense mechanism exhibited by hosts against invasion by any foreign antigen, including microorganisms. The normal immune system is essential for protection against infection, but it is like a double-edged sword. A hyperactive response can be fatal. Hailing the father of immunology, Louis Pasteur. Now, broadly, immunity can be classified into innate immunity and adaptive immunity. Innate immunity further includes physical barriers, chemical barriers, and cellular defenses. Adaptive immunity can be active or passive. Active immunity includes natural encounter with diseases or vaccination. Passive immunity includes maternal and artificial antibodies. These are the cells of the immune system. Starting from the hematopoietic stem cell, we have lymphoid and myeloid lineage. The lymphoid lineage, the first cell is lymphoid progenitor, which differentiates into B cell progenitor, natural killer cell, and T cell progenitor. Further, on countering the antigen, B cell progenitor differentiates into memory B cell and plasma cell. T cell progenitor in the same way differentiates into memory T cell, cytotoxic T cell, and helper T cells. The myeloid progenitor differentiates into neutrophils, eosinophils, monocytes, mast cells, and basophils. Now, looking forward to T lymphocytes, they develop from precursors in the thymus. T cell recognizes a specific cell-bound antigen by means of an antigen-specific T cell receptor, or TCR. So T cell receptors are made up of two polypeptide chains that together compose one antigen binding region. TCRs are composed of an alpha and a beta chain, as you can see in the image. The T cell receptor structure is maintained by a disulfide bond linking the two chains together. Complementary determining regions, or CDRs, are key structural features that lie within the variable region and provide specificity in antigen binding. So the T cell receptor on a CD4 plus T cell recognizes the pathogen peptide displayed on the surface of an antigen presenting cell with MHC class II only. Different types of helper T cells are produced depending on the type of the pathogen that is recognized. The T cell receptor on a CD8 plus T cell recognizes the pathogen peptide displayed on the surface of an infected cell with MHC class 1. The T cell releases cytotoxic molecules that kill the infected cell and stop the pathogen from spreading. So this is a summary. When an immature CD4 T cell receptor counters with MHC class 2, it differentiates into mature helper T cell. Similarly, an immature CD8 T cell, when counters with MHC class 1, differentiates into mature cytotoxic T cell. Thank you.
Thank you, Aditi. I think that opens a perfect platform for continuing this talk. I now kindly request Dr. Naveen Kadri, sir, the pioneer in CAR-T studies and CAR-T therapy, to build the bridge from immunology to hematology. Over to you, sir. We have few questions which the students have provided, and we shall go through the questions. Can we start, sir? Sir, can you unmute yourself, sir?
Sorry. Thank you, Kartika. Firstly, I would like to thank the Amrita Institute of Medical Sciences organizing committee to give an opportunity to be here. While we may have started the CAR-T program in our institute, I am not driving it completely. It is my colleagues. And it's an honor that we have people in our institute who have made it possible in the country. And of course, there'll be many more centers who will be doing it in the next few months to years. Can I think I have the right to share the screen, isn't it? I just wanted to, just a second. There. So, Dr. Kartika, can you see the slide set? Is it
yes,
visible?
sir, we can see it, sir. Can you put it on the slideshow mode, sir?
I think Aditi has done a great job. I mean, I don't think I knew anything like this when I was in third year MBBS, and I'm impressed. Both the first student as well as Aditi, the second student, they know much more than I knew when I was an MBBS student. So should we go by the questions which the students have put in,
yes,
or?
Can I read it out for you, sir?
Sure.
So the first question is, what is CAR-T indicated for?
So I will go to the second slide and then I'll come to the first slide. While the transplant has been there for more than 50 years, and Dr. Biju George had very eloquently presented in such a simplistic manner, the CAR-T technology is not that old. It's around maybe 10 years, though the concept of T cell causing destruction of tumor is more than 40, 50 years old. While it started in hematological malignancies, there is also space that it probably will come in the context of solid tumors, but I think it will take more time because I think the hematological malignancies are probably more immune mediated, and that is why you will see that the indications of CAR T cell are more in the hematological malignancies. So the first disease, which is not mentioned here, is the chronic lymphocytic leukemia. It was way back in 2011 that the results were published. However, the results were not very good. The promising results are more in the B-cell lymphomas and acute lymphoblastic leukemia of the B lineage. Dr. Revati, in our presentations, spoke about ALL in a very nice manner, and she did mention the CAR T cell being used in ALL. So the B lineage ALL, there are two, B and T. So the B lineage ALL is one of the foremost indication for CAR T cell. And that is more in those patients who relapse after upfront chemotherapy, or if they relapse after bone marrow transplantation. The second group of diseases in which CAR T cell is indicated, and we have many CAR T products which are now available, is the B cell non-Hodgkin lymphoma. Now, the B cell non-Hodgkin lymphoma is a huge group in which the most important is the diffuse large B cell lymphoma. It's one of the types of B cell lymphoma. Then there is follicular lymphoma. There is mantle cell lymphoma. So in these, CAR T cell has been found to be effective. Again, it is in those patients who relapse after the upfront standard treatment, or those patients who whose disease do not get controlled with the upfront treatment. So in both these indications, the CAR T cell has been found to be a promising treatment in these lymphomas. The other disease of the hematological malignancies is multiple myeloma. And here again, there is emerging data that CAR T cell may be useful. Again, not upfront. Upfront, we have many treatment strategies in multiple myeloma which can keep the disease under control. However, when the drugs which we have right now cannot keep the disease under control, then again, CAR T cell is one of the promising strategies in which it helps. And both relapse after chemotherapy, or what we don't say chemotherapy, we say immunomodulatory agents or proteasome inhibitors in myeloma. If they relapse after that, or if they relapse after autologous transplant in myeloma, it is a useful strategy. So this is for the hematological malignancies. In solid tumor, it is not easy because there are far more escape mechanisms. Wherever the disease is immunogenic, CAR T cell will probably help. And the immunogenic tumors in solid tumors are melanoma and renal cell carcinoma. These are two very important immunogenic tumors. So though it is not completely, this strategy is probably not as useful in these diseases as yet, but in the future, I think it's going to be useful in these diseases also. So yes, so the next is the USA FDA, which is the licensing agency which allows drugs to be used outside clinical trial. You can see that there are quite a few of these CAR T cell products which are available, and their generic names are tongue twisters. I can't even pronounce them. The name, which is the commercial name, is probably easier to pronounce. And you can see that some of them are already available commercially, at least in United States of America. There are some which are already available in China. In the rest of the world, mostly it would be in clinical trials, and until unless the countries, their regulatory authorities approve the sale of these commercial products, it will take time to come to many other countries. I think we can go to the next question. What was the...
Sure, sir. So the next question is, how does it work?
So before I go to how does it work, this is a picture which is, I believe, abused again and again across the world in the last many years, because it shows the hope that advancement in science can really bring a change. So this picture is of a young girl who had a refractory acute lymphoblastic leukemia. She relapsed even after bone marrow transplantation. There was no hope that she would live. And she was given the CAR T product, and she is probably more than 6 or 7 years after the treatment, and she's doing very well. So, this is something which is used again and again, just like the slides which Dr. Biju George presented for transplantation. Donald Thomas is everywhere. Emily Whitehead is also everywhere. And I'm sure in the next few years also, she will be quoted in most of the presentations because of what has changed the way we look at these diseases. Now, how does it work? Aditi, she did a fantastic job of trying to explain the T cell receptor. To be honest, I still don't understand what the T cell receptor is. So, in the normal physiology, you need the T cell receptor and you need these antigen presenting cell. Here it is a tumor cells, but you need the antigen presenting cells, which with the major histocompatibility complex on the cell surface have the peptides expressed. Now this T cell receptor binds with the peptides which are there on this MHC complex, which is obviously HLA genes, proteins expressed on this. And when they recognize it, then something happens here. The cell is destroyed. So all the foreign peptide cells are destroyed. The self cells are never destroyed unless they develop autoimmune disorders, because there are checks and balances in the body to prevent the self from being destroyed. Now here, it's a tumor cell. You need the T cell receptor. You need the peptide of the tumor cell with tumor antigen linked with the HLA, and then only this destruction happens. Now, what happens many times is that the tumors are very clever. The tumor cell is very clever. They downplay the HLA protein onto the surface. Now, if you downplay the HLA protein onto the surface, then the T cell cannot recognize to the T cell receptor because the HLA is already downregulated. When this happens, the tumor cell escapes the T cell attack onto the tumor cell. And this is exactly what happens, why many patients fail even bone marrow transplantation, because the T cells, which are the most important cells to protect against disease recurrence after transplant, they recur because obviously the T cells are no longer helpful in keeping the disease under control. Now, what does CAR T do? It's basically genetic engineering. And in that, I will come to the next slide of how it is done. But the T cells, which are genetically engineered, and these are T cells of the patient, they are made to have a designer molecule on the surface, which then attacks some of the specific antigens which are present on the tumor cells. Now, in the context of B-ALL, that is B lineage acute lymphoblastic leukemia, and B non-Hodgkin lymphomas, CD19 and CD22 are two clusters of proteins which are very important for the survival of the tumor cells. Now, when these T cells, which have been designed to express a designer molecule which is known as CAR, chimeric antigen receptor, they don't need the MHC to attack the tumor. They can directly attack. So you bypass this mechanism for the usual way of T cells destroying the tumor. This then leads to the destruction of the tumor, and that is how the disease can get controlled. So what is the CAR T cell? Now, Aditi very nicely talked about the T cell receptor in a normal cell. So what do you do in CAR T? You take the T cells from the patient, and then you try to put a transgene, that is gene, which will then express something like this, where you will have some properties of a normal T cell receptor, like the stimulator signal here of the theta subunit, But then a part of it is a designer, which is basically the fragment, the single chain variable fragment of the immunoglobulin receptor, the light chain and the heavy chain. Now with this T cell subunit here has two purposes. This will bind to the antigen, which is on the tumor cell. And then this part will then lead to the activation of the T cell, liberating of various cytokines which will destroy the tumor. And when you do this, then you don't need the usual T cell receptor interaction with the major histocompatibility complex, either on the tumor or on the antigen presenting cell. Now, CAR-T has come up in the last 8 to 10 years. So this was first generation in which the scientists had to improvise because they did not last long into the body to keep the disease under control. Then came the second generation in which a co-stimulatory receptor domain on the T cell receptor was put in so that the T cells remain activated. And there's something known as CD28 or a 4-1BB. These are co-stimulatory domains. So it enhances the T cell activation. And then there's this third generation in which both are inserted. So basically, it only means that the CAR-T is like a designer receptor trying, and there's improvisation happening in the years to make it more active so that it can destroy the tumor cells. But how does that designer receptor get into the T cells? The designer receptors get into the T cells by either viral vectors or non-viral vectors. Now, what is a vector? So basically, a vector is something which will transport some of the genes which we want expressed into the cell and integrate into the genome of the host cell. So here you have a virus. That virus is constructed with a transgene, which is basically what you want expressed into the virus vector. And here you would want that designer receptor gene to be integrated into the virus vector. Once it is integrated into the virus vector, you incubate the vector with the T cells which you have isolated. After some time, some of those T cells will have the vector integrated into the T cell genome. And when the T cell genome has been integrated with the viral vector, the virus will not be produced because you've made sure that the virus efficiency is not there for virus to be produced. But the T cell designer molecule which you want it to produce on the T cell, that gets expressed. And that is how it then gets expressed onto the T cells. So what happens is you do a stem cell, you do a pheresis, which means you take out leukocytes from the patient. You isolate the T cells from that. After the T cell collection, you activate the T cells with some cytokines and put the virus vector into it. You can also have non-virus vectors to do it. Then you expand these T cells, and then the T cells are then stored in freezers till you want it infused. And when you want it infused, you give some gentle chemotherapy, not the chemotherapy what Dr. Biju George explained for bone marrow transplant. There you need strong chemotherapy or strong radiotherapy to condition the patient. Here you give gentle chemotherapy, enough to condition the patient so that these designer CAR T cells thrive into the body when they go in. And once they go in, then in the next 2 to 3 weeks, as they get exposed to the cancer cell, these T cells starts proliferating. And these T cells then keep on trying to destroy the cancer cells. So this is a beautiful way of, you exploiting immunology in medicine. where you know that the T cells are required for destroying the cancer cell, but you're not sure how to do it. You have these designer receptors on the surface, which are specific for the antigens on the tumor cells. You allow these cells to then expand in the body so that they can be destroyed. So while it all looks simple, but of course it takes years of laboratory medicine to be harnessed so that this can happen. Now this all happens in labs where you have good manufacturing practices, but this may not be possible in many centers across the world. So can you do it in a more simplified way, like what Dr. Neeraj and Dr. Biju were talking about, cyclophosphamide for half-match transplant, so that it is more universally acceptable? For that, now there are closed systems in which all these steps which I just alluded to can be done. So you don't have to be in a lab. You can put this machine anywhere, and all this process and steps which I explained here can be done in this machine. So after maybe 2 weeks, a product comes out, and that product can be stored in freezers till you need to infuse it to a patient. However, nothing comes free in life. So right now, this closed system is very expensive. It is a monopoly of one of the companies. However, the next 10 years, certainly, I think there will be more of these systems which will come up, and hopefully it will come to the reach of many across the world. So I think that is probably, how the CAR T cell would work, and the steps in which, how it is done. What's the next question, Dr. Karthika?
So the next question is it expensive?
Right. So I'll go to the last slide. So if you look at this one, this is in United States of America. So Yescarta, which is a CAR T cell product, right now the tag is something like $400,000. And then Kymria is another of the commercially available T cell, CAR T cell product, which is nearly $500,000. This is only the product. However, that is only one part of the cost. The cost is also in the chemotherapy which needs to be given, the treatment for the side effects, then the admission of the patient. So, there are lots of other costs which are not put in together when we say $500,000. So right now, what is available commercially in the world is anything between $500,000 to $0.75 million, which if you convert to Indian rupees, it's really very expensive. But this will change. And the reason it will change is just like any new technology, things do become cheaper till it reaches the doorstep of every person who can, for whom that, that strategy can be useful. In India, there are already a lot of attempts to make it cheaper. We have already started the trial in ACTREC, and we already have few patients on our lymphoma trial, as well as on our acute lymphoblastic lymphoma trial. But there are other institutes also in the country who will most likely bring this technology. And once it comes in other institutes, certainly in India, the cost will come down, because we know that anything which is expensive in US and Europe certainly is much cheaper in the country. So I'm very hopeful in the next few years, this cost will certainly come down in our country. It's just like bone marrow transplant. The bone marrow transplant in US is anything between $200,000 to $400,000. And in India, the cost of doing a transplant is anywhere between 10 lakhs to 30 lakhs, which is probably 1/6 or 1/8 of the cost in the Western world. Next
Sure.
question, Mr. Karthika.
Yes, sir. The next questions the students want to know is on the side effects of the CAR T therapy, sir.
So nothing comes free. So while the technology is good, very promising, and hopefully it will revolutionize treatment in many cancers, you can divide it into 4 groups where the side effects can come. You have a vector, and you're introducing a gene into the human genome. Now, there's always a theoretical risk that if you put this vector into the T cell gene, it may mutate and can cause cancer. And that is known as insertional oncogenesis, where you insert a gene and the gene goes berserk, or the neighboring gene goes berserk, and it can cause cancer. Now, that has happened in the gene therapy, which was first used for immune deficiency diseases, which is one of the most difficult diseases, the severe combined immune deficiency. And there, when the gene therapy was done, there were malignancies which happened later. Now, it happened in that context because it was the stem cells which were fiddled around with this gene. Here it is the T cells. The T cell genome has most of those genes which can potentially cause problem silenced. And that is why when the chimeric antigen receptor gene, the designer receptor gene, which is integrated into the T cell genome, though there could be theoretical risk of cancer, in the last 10 years, even not a single one has been found to develop cancer. So probably this is theoretical, but we must keep this in mind. What happens in nearly half the patients is a cytokine release syndrome. When the T cells become active, when they see the antigen on the tumor cell, they become hyperproliferative. And when they get hyperproliferative, they liberate a lot of cytokines, and their neighboring cells which also come together, just like herd mentality. Everyone comes together. So the macrophages come in, the monocytes come in, the T cells are already there, and then they liberate a lot of cytokines because they want to destroy the tumor. That leads to something like a systemic inflammatory response syndrome, which is like having hypotension, hypoxia, neurological problems, and renal problems, cardiac problems. So that is probably the most important side effect. And now we have good drugs to prevent it, because interleukin-6 is one of the most important cytokine liberated, and one of the cytokines which actually cause a lot of problems inside the body. If you give an antibody against interleukin-6, which is known as tocilizumab, then you can blunt the cytokine release syndrome. The other drug which is very helpful is steroids, but the problem with steroids is that while it will dampen this cytokine syndrome, it can also dampen the activity of the T cells. So there is always this worry, if you dampen the activity of these CAR T cells, then probably your response on the tumor may also be less. So tocilizumab is used in this syndrome, and many would know that tocilizumab has also been used in COVID infection with lung injury, because there too, the interleukin-6 is very high. Then you can develop allergy, anaphylaxis, because the receptor on the surface of the T cell have proteins which are not the usual protein in the patient body. And any of that peptide area can lead to an anaphylactic reaction. It is possible, but it has not been seen to the effect that one should really worry too much. Then the other side effect, so like in B cell, what in B cell lymphomas and in B lineage ALL, what are we targeting? The CD90. So this CAR T cell will destroy the malignant cell, which is CD19, which has the CD19 antigen on the surface. But CD19 is also present in normal cells. And what are those normal cells? The B cells. So it will also attack these B cells because they express the CD19. So what classically you see with the CAR T against the CD19, which is known as the CD19 CAR, you also see aplasia of the B cells. That means the B cells, the normal B cells go down in the body. And this can increase the risk of infection. So how do you prevent that? You only prevent that by actually giving immunoglobulins in regular periods. Because what is the most important function of the B cell? To produce immunoglobulins to fight infections. So if you supplant that from outside by giving immunoglobulin infusions, there will be a lower risk of infections which may happen because of this B cell aplasia. So this is in the context of the CD19 CAR T, where the CD19 is the target. However, you will have CD22 targets, you will have in myeloma many antigens, you will have in some solid tumors many antigens. Now, if those antigens are expressed on normal tissue, then there could be a problem. And that has happened with solid tumor. So there is something known as the HER2/neu on a breast cancer. Now, HER2/neu receptors are also present in normal cells. So when the CAR T was used in breast cancer, there were few deaths. And the deaths were because of some of the toxicity which happened in the normal tissue. So the toxicity which may happen on the B cell is easy to replace because you just have to give immunoglobulins. But toxicity in some other tissues can be a problem. So a lot of improvisation will be required in the next 2 decades to make this CAR T cell promising in many of the other diseases, because a lot more needs to be learned before it could be used. And these are all the organs where toxicity can happen. No organ can be spared. And we just need to know how to treat, and if we can prevent some of these toxicities, but it could be any organ which can be affected because of the cytokines. Over to you, Dr. Karthika.
The next question, sir, is who are the apt candidates for CAR T therapy?
So as I said, it was more of those who have disease which does not respond to the upfront treatment, or those who relapse, and the standard treatments which are being used right now, they don't work on those. So suppose you have an ALL patient who does not go into remission even with the upfront treatment, or those who relapse and even bone marrow transplant fails in those patients, then CAR T cell would be the ideal treatment. However, as we get to know more and more about how the CAR T cells are working, and more centers develop the technology on how to produce these CAR T cells, and if it becomes cheaper, probably it may come up in the earlier part of the disease. Right now, whether it's non-Hodgkin lymphoma or ALL, it is usually reserved for diseases which are not controlled by the current standard treatment.
The next question, sir, why does it fail? Also, I take the liberty of adding a first part to it. Does it actually fail? And if so, why does it fail?
So no treatment is perfect. You know, if everything was perfect, then science will not evolve. Then we will have nothing to think about. So why does it fail? There are many reasons for it. First of all, does it cure all patients? No. So whatever we know in the last 10 years, around half the patient will probably have a long-term remission. We are not sure whether they'll get cured, but probably they will remain without disease for many years. The other half, the disease will come back, and some of them may not have the disease getting controlled even initially. Now, There are many steps in the CAR T cell where it can fail. Number one is when you collect the lymphocytes from the patient, to make it activated with the designer receptor, you may not have enough lymphocytes in your body. If you don't have enough lymphocytes in the body, probably you will not be able to generate those CAR T cells. And if you cannot generate those CAR T cells in the lab, that's the end of it. You will not get that CAR T cell back into the patient. So that's the first part. Secondly, if you have a CD19, I will explain in the context of ALL and non-Hodgkin lymphoma. Your target is CD19 because you have the CD19 here, a designer CAR T being produced, and the tumor is here, and then you destroy it. But what happens? The cancer cells are clever. The cancer cells come back with a new receptor on them. So the CD22 is another one of it. So while the CD19 tumors would have destroyed, but there are some which will remain CD22 expressed or any other tumor antigen expressed. And when they are present, then obviously the CD19 CAR T cell may not work at all. Another important one is how long will this CAR T cells remain in the body? What we know right now is probably they will remain for 6 months to 1 year maximum, but that is the time when they will do whatever they need to do. But if the CAR T cells do not remain for a longish time, then it will not be able to eradicate the last cancer cell anyways. So a lot of improvisation is going on to make sure that these CAR T cells remain for a long time. Because, if you flog a horse a lot, then what will happen? Similarly, the T cells, when you stimulate them too much by exposing them to a tumor, it will get exhausted. And if it doesn't produce the memory CAR T cell so that it remembers that it needs to attack the tumor again and again, it will vanish. So, these are some of the mechanisms by which the CAR T may not work. And that's exactly what happens, that in half of them, the disease may come back. In order to prevent it from coming back, a lot of improvisations are being made. And this is early on in this sphere. And I think we will get to know more about it in the coming years of how to prevent resistance.
So the last question for yourself, how long does it take to work?
So it's the usual physiology of the T cell. You give the CAR T, it takes at least some time for them to expand as soon as they come across the tumor. And that usually takes around 2 weeks. So you will have a classical surge of the T cell expansion, which will be for 2 weeks. And then slowly, as they get destroyed, it will come to a lowish level, persisting so that the residual tumor cells can get destroyed. So the end point of the trials which were done in the last 10 years has been looking at the bone marrow or the PET scan, if it's lymphomas, at day 28, and then again at day 90, and so on and so forth. But the time period in which the T cell expansion happens, it happens in the 2 to 3 weeks when it needs to happen. So you will probably get to know early on whether the disease will remain controlled or not. Unlike in many other therapies that you have to patiently wait for a long time to understand whether the disease is in control or not. Especially in cancer, you have to give around 6 cycles of chemotherapy for any tumor, and then you have to see whether you've got a complete remission or not. Here, within a month to 3 months, you will know how many CAR T cells are persisting. If they've already vanished and the disease is not under control, that means it would not work. And then you will have to then plan your next strategy.
Thank you, sir. That was an absolutely wonderful way of hand-holding us into this world of genetic engineering, CAR T cell therapy, and its applications in hematological malignancies. I request you to be logged in, sir, so that we can take rest of the questions which have been coming through the session.
Sure. Thank you. Thank you very much. I think I have to stop the share screen.
Now, I would like to thank Dr. Karthika, Dr. Naveen Kadri, and Aditi Arora for their valuable contribution towards this session. Now, I kindly request Dr. Princey Louis Pilati to take over. Over to you.
So good evening, everyone. Thanks to Dr. Neeraj, our principal, and the whole SPUSH organizing team for inviting me here. And I have the great privilege on behalf of Amrita Institute of Medical Sciences to put forth this session on chronic myeloid leukemia. Chronic myeloid leukemia, two keywords, slowly progressing and adults, right? And to do the honors, we will take student perspective from Miss Naina Joseph from the third year, and also the stalwart in this, that is Dr. Suman Kumar. I shall introduce Dr. Suman Kumar just as soon as our student perspective is completed. Over to you, Naina.
Thank you so much for this opportunity. Good evening, everyone. Today, I'll be presenting chronic myelogenous leukemia from a student's perspective. CML is an acquired chronic proliferative neoplasm of the abnormal pluripotent hematopoietic stem cell caused due to the balanced reciprocal translocation between long arm of chromosome 9 and chromosome 22. This forms Philadelphia chromosome. At the molecular and genetic level, the proto-oncogene, namely ABL1 gene from chromosome 9, joins the BCR on chromosome 22. This results in chimeric or fusion gene called BCR-ABL1. Now, ABL1 proto-oncogene is converted into a functioning oncogene with enhanced tyrosine kinase activity. So this is a diagram here. We can see ABL1 gene on chromosome 9 and BCR gene on chromosome 22, which undergoes reciprocal translocation to form Philadelphia chromosome. The abnormal activation of tyrosine kinase due to mutation leads to abnormal downstream oncogenic signaling. This eventually causes proliferation of stem cells that compete with normal cells and suppress normal hematopoiesis. Now, there are three stages of CML. First stage is chronic phase, second stage is accelerated phase, and third stage is blast phase. To put translocation in simple words, translocation is a chromosomal abnormality whereby there's a break in one particular chromosome, and that chromosome will then fuse to a different chromosome to finally form fusion product. Diagnosis and treatment of CML. Now, Philadelphia chromosome can be demonstrated through FISH, fluorescent in situ hybridization. Treatment can be done through tyrosine kinase inhibitors like imatinib. So this is a diagram of FISH. FISH uses color probes that bind to DNA to locate the BCR and ABL1 genes in chromosomes. Thank you so much.
Thank you. That was Ms. Naina Joseph, our third year student from Amrita Institute of Medical Sciences, who took an opener into CML. Today we have with us Dr. Suman Kumar, who has taken MBBS and MD from the Armed Forces Medical College and DNB from AIMS, and also is currently the senior advisor at the Department of Clinical Hemato-Oncology at a wonderful, impressive building with impressive people in it. That is the Army Research and Referral Hospital at Delhi. Always we see that building. That's why I'm happy to meet you, Dr. Suman Kumar. And they will be taking us through all the aspects of CML. I have some questions here, and this shall be put to you to first itself so that you can highlight these aspects as you take your session today, Dr. Suman Kumar. So the students have brought out, they really want to know about the history of how did Philadelphia chromosome come about. They would also like to know how to diagnose and how do you treat early treatment of CML. And recently, into early 2000s, there was a breakthrough. They would like to know much more about it and how you go about, what is the algorithm? How do you go about diagnosing and treating a case of CML? Over to you, Dr. Suman Kumar.
Thanks a lot, all of you. And I hope I'm audible.
Yes.
Madam, am I audible?
Yes, you're audible.
So thanks a lot. And I want to thank the organizing committee for giving me this opportunity to talk about one of the very simple that is chronic myeloid leukemia. And so without further ado, I'll just start the talk. I'll be trying to cover all the points which are raised by the students, and about 50-60% of my talk has been already covered by Naina, that is with the third year student who has already done it. And so I just start the talk. I first share my screen, and yeah. So I think the screen is shared. I think it is about to be shared.
Yeah, right. Yes, you're visible. Your slide is visible.
Thank you. So firstly, a CML, as we have already told, a CML is a cancer of bone marrow stem cells. So it is a cancer of a stem cell. That is very important. And World Health Organization, it has classified CML as a myeloproliferative disease. So there are two terms in it: myeloproliferation, that is, there is a myeloid component, as we all know, and there is a proliferation that is taking place. And the very, very characteristic feature in this is the presence of Philadelphia chromosome, or this BCR-ABL fusion oncogene. In fact, this is the defining feature. This is the defining feature of this disease, and more so because we have got targeted therapy for it. So it occurs about all the malignancies in hematology. 1 in 1 lakh population is the usual, 1 or 2 times more than that or less than that is the usual prevalence rate. So it is a very common disease, a very common malignancy in hematology in adult leukemias, about 1 in 5 cases, and slightly male preponderance is there, with median age at diagnosis of 60 to 65 years. So as it has already been told, it is a disease which is very simple to start with, a disease which is easily controllable, a single mutation or single translocation which is there and leads to chronic phase, and then the disease progresses and it gradually gets more and more violent in nature and more refractory to treatment, and it finally reaches the blast crisis. So most of the patients are diagnosed in the chronic phase, and where they are often asymptomatic or they're incidentally diagnosed, and if untreated, almost all the patients, they progress within 3 to 5 years. Now, the first question was, how was this Philadelphia chromosome identified? Now, this disease of chronic myeloid leukemia was known to mankind since very long, and it was in 1845 when Rudolf Virchow and John Bennett, they described the first case of CML when they found lots of this white blood cells in their peripheral blood smear. They were initially confused that whether it was infection, or it was a malignancy, or it is a neoplastic change. But later on, they came to a conclusion that it was a neoplastic in nature. It was only in 1960 that Peter C. Nowell, he was a pathologist, and he, in his microscopes, he started seeing that the chromosome patterns in these group of patients, they are exceedingly common. They're at 90 to 95% of cells, the cancer cells, they are having the same sort of chromosomal pattern. So then he called on David Hungerford, who was doing his PhD, and he was a cytogenicist. And both of them, they characterized this abnormal chromosome, which was very unfortunate for the cancer. It was very unfortunate for the cancer, but very fortunate for the mankind that they identified it, and they identified it as an abnormal chromosome, and they called it a Philadelphia chromosome. It was till now, we do not know that this is the driver chromosome or chromosomal abnormality. We just know that this disease is associated with this chromosome. Then it was in 1973 that Janet Rowley determined that this abnormal chromosome, which was identified by Hungerford and by Nowell, it results from the exchange of genetic material between these two chromosomes. And this is the driving cause of the chronic myeloid leukemia. Before I proceed further, this is the most important slide that we should remember if we are going to diagnose any cancer, and more so a disease like CML. Now, this is the central dogma of genetics, as we all know. This is our thinking right now, and this thinking might change in future, but this is what we know as of now, and we all know it in our pre-MBBS days also, that we have got DNA. Now, DNA is present in all the cells, and it is hard-coded. At the time, from the time we are born, this DNA, it is hard-coded. Other than the mutations which take place, this is hard-coded and they are fixed. And from this DNA, there is a transcription, and by the transcription, it produces a messenger RNA. Now, the transcription is regulated. The transcription is not all and none phenomenon. It is regulated by various mechanisms called as epigenetic mechanisms, and by the presence of various transcription factors. And these then produce the messenger RNAs, which are in variable quantities, depending on the cell types, depending on the age of the cell, depending on the age of the patient, depending on the amount of transcription factors and amount of epigenetic factors. This mRNA is variable quantity per cell. This mRNA, we have to remember that it is very rapidly degraded. From the mRNA comes the proteins. Now, proteins are, again, there are translations which occur from this mRNA, and these are the main effectors. The proteins are the main effectors by which we see the various effects inside our body. Again, they are variable quantities. Again, they are degraded. mRNAs and proteins, they are the groups of molecules which act as transcription factors for DNA. So there is a sort of a negative feedback regulation is also present in this whole central dogma. If you see a normal cell, as far as the CML goes, in a normal cell, in the chromosome 9, we have got this CABL gene, has already been described. It's an Abelson gene. It is a proto-oncogene. What is a proto-oncogene? Proto-oncogene is a gene whose proteins, they cause the cell proliferation. They cause the increased cell survival. Now, this CABL, it is again regulated by various epigenetic factors and various transcription factors, and it produces the CABL mRNAs. From the CABL mRNA, it produces the tyrosine kinase, a specific tyrosine kinase whose job is to increase the cell proliferation and survival. But we should remember that this whole process in a normal cell is well regulated under lots of known and unknown negative feedback mechanisms. What happens in a CML cell is that, now we have to understand that CML is one of the very, very unlucky cancers, very few unlucky cancers which has got this single driver mutation and which we have been able to catch it. And that is why this disease has come under such tremendous pressure of dying or death, you can say. Now, in a CML cell, because of this translocation, the translocation can either be microscopic translocation, which leads to the juxtaposition of a part of this BCR region in the 22 chromosome with the Abelson gene, that is ABL, and it forms a part of the gene which is the fusion gene, which is known as BCR-ABL. Now, this fusion gene It is not under any transcription factor. It is not under any epigenetic control. So this fusion gene is always active. So once this gene is always active, it is always producing something. What it is producing? It is producing the BCR-ABL messenger RNA. And then it is producing the tyrosine kinase, the BCR-ABL tyrosine kinase. And this leads to unregulated cell proliferation and increased survival of this CML cell. So this is the, in nutshell, how a CML cell it is becoming a CML cell. Now later on, because of the increased proliferation, the number of CML cells in the body increases. So as the cells are more proliferating, just by random mutations, there are increasing numbers of random mutations. And one of these random mutations, when it occurs in a part of the genome, which leads to differentiation block. Differentiation block means from the myeloblast stage, it is not able to proceed further to produce. It is not able to proceed further to the neutrophil phase or to the neutrophils. This disease, it just progresses and it forms acute leukemia. And acute leukemia it is also known as this blast crisis. Once there is a differentiation block, there is increased cell proliferation and increased cell accumulation inside the bone marrow, which leads to bone marrow failure, and it also leads to the deposition of these blasts all across the body and creating a chaos inside the whole. That is the patient. So this was the basic result of CML. Now CML, till the time we knew about this Philadelphia chromosome and we knew about this BCR-ABL gene, the CML was also treated like other malignancies in a sort of a carpet bombing fashion. In a carpet bombing fashion that we used to treat, non-specific drugs were given, non-specific chemotherapeutic drugs were given to kill these CML cells. Had kind of success stories in cancer. It was formerly a fatal blood cancer with a fatal blood cancer with a median overall survival of 3 to 6 years and annual mortality rate of around 15 to 20% of patients. The treatment had gradually progressed from arsenicals in 19th century to early 1900s radiotherapy, especially when the patient had large and huge spleens. Then it became a non-specific alkylating agents like busulfan and then hydroxyurea. Then came the allogenic stem cell transplantations in 1980s when the stem cell transplant process became more mature, and then the patient, then doctors started treating them with allogenic stem cell transplantation. Then came the interferon alpha in 1980s, but the magic came in 2000. Inhibitor, that is imatinib, was approved.
Excuse me, sir. Excuse me, sir.
Hello. Yes.
Yeah, your slide, you're audible, but your slides are not visible, sir. Just a minute or two ago. Could you?
Yeah, just a minute.
Yeah.
Oh, I think I've lost.
Yeah, it's okay. Oh, do you want us to play the slides from here? Because
it will be. It will be nice.
Yeah,
it will be nice.
Yeah, we will play it from here. Just hold on, sir. Just give us 2 minutes.
Excuse me, sir. We apologize for the delay, sir.
It doesn't matter. It doesn't matter. It's my thing only. Not going to.
Sir, can we please know the slide number?
Yeah, you can go to slide number is 13. You can,
Okay,
or 12.
sir.
You can play.
Okay, sir.
Yeah, thank you. I think this is the one. Yeah, pre-imatinib story. Yeah, this is the slide. Absolutely. Yeah. So it was earlier on. It just started off bombardment or if in a sort of a generalized way to treat malignancies with generalized sort of chemotherapeutic agents. But it was only in 2000, that is 2001 and onwards, that we developed a sort of a targeted therapy against this disease. Next slide. So before we go forth, few of the important, like a few of the agents which we used to use earlier on, and so like busulfan we used to use. It was quite inexpensive and it was very good in controlling the hematological variables. But ultimately, in about a year's time, 3 to 5 years time, the patient used to relapse and went into blast crisis. It had prolonged myelosuppression, and it had a very bad side effect of involving the lungs, and it led to busulfan lung, something which is known as busulfan lung. Then we had all the very commonly present also, we use this drug, the hydroxyurea. It had again some effect of control of the disease, and it used to be preferred for patients who were considered for bone marrow transplantation. It is still used, but only in the initial phase to reduce the counts, and it has gotten important adverse effects of mouth sores, ulcers, and skin rashes. Interferon alpha was the former first-line therapy, which was there before the advent of the tyrosine kinase inhibitors. It had shown a tremendous degree of hematological improvement of around 75%, and with 10% of patients achieving cytogenetic remission. It was quite a deep remission as per those days, 1980s, and it is still in use for refractory patients with the newer agents like with the tyrosine kinase inhibitors, and CML patients who want to conceive, because tyrosine kinase inhibitors are not indicated in patients who are pregnant. Then stem cell transplantation was again, once upon a time, it was for all the patients who had matched sibling donors available with us. Stem cell transplantation was considered to be the standard of care, but it has again gone to the background or the sidelines because of the presence of this magical drug of tyrosine kinase inhibitor. Next slide, please. So if you see the survival of the patients, from 1980s to 2008, we can see the topmost blue line, and we can see the progressively over the years, as we have developed newer and newer agents, we have seen the survival of these patients. They have improved, but the magical improvement came where no statistical tests were required to be done, was when imatinib was discovered in 2001 and 2002. And after that, the CML has really become a chronic disease with long survival. So this was the next slide, please. So this was the Time magazine where they have written, it was 2001 edition, where it has been highlighted that there is a new ammunition in the war against cancer, and these are the bullets. So drug of this drug of tyrosine kinase inhibitor, it started next slide, please. It ushered a new era of targeted therapy. It was a team from the Novartis group, that is Brian J. Drucker and Leiden and Sowers, who broke a new ground in cancer therapy, where they seized upon the molecular defect that underlies the CML, and they formulated the idea of tackling the root cause of the disease. And they literally crafted a specific kinase inhibitor, which was known as imatinib, which was known as Lymphatic by that particular group, that is Novartis group, and it radically altered the prognosis of the CML patient, and it converted a fatal cancer into a manageable chronic disease. Now, this therapy, this way of therapy, this paradigm of therapy, it has since then extended well beyond CML, and it has just is everywhere in the cancer management nowadays. Next slide, please. So it was in May 10th, 2001, that imatinib was FDA approved as a first-line therapy. Now, see, it is in the first-line therapy for the patient with CML, AP, BC, that is accelerated phase, or blast phase, or CML CP patient, that is chronic phase patient, who had not responded to interferon alpha. When was done, carried out head-to-head trial showing the standard of the care that time, that is interferon alpha and intervene, with the block drug, that is the experimental drug, that is imatinib, and it had shown that imatinib was any day superior to that time standard of care combination of interferon alpha with cytarabine. In that, you compare 10% complete cytogenetic response with interferon alpha, and now patients are achieving 82% complete cytogenetic response, and only 17% of them relapse. Only 3% of them progress to accelerated phase and last crisis, and only 2% resulted in death. So that was the massive change and the massive improvement that happened with the advent of this tyrosine kinase inhibitor, that there was no statistical test were required to prove that this was a superior therapy. And all of the patients who were on this other arm were subsequently shifted and to the imatinib arm. Many of those patients who were initially treated in this IRIS trial are still alive today, taking this wonderful drug. The impact of TKIs came in this Swedish study, and this Swedish study, very beautiful, elegantly, they have demonstrated that from 1990s, in both the males and the females, the topmost, the 1992 onwards, the life expectancy of the patients of CML has progressively improved, and now they are almost touching the life expectancy of the normal general population in those years. Now, how do we go about treating a case of CML? So that was the next question that was asked. Now, tyrosine kinase inhibitors, that is, I will be talking only about imatinib. There are various other tyrosine kinase, second generation, third generation tyrosine kinase inhibitors are available right now. So these are the tyrosine kinase, these are the inhibitors which act on the proteins. So they are ABL specific. They act on the tyrosine kinase of the ABL gene, and they inhibit the ATP binding. They lead to blockage of the phosphorylation, thereby preventing any downstream signal, thus inhibiting the proliferation of CML cell lines. It is important for us to understand that these tyrosine kinase inhibitors, they act at the level of proteins. It's very important for us to understand. Next slide, please. Next slide, please. Yeah, it is absolutely important for us to understand that this tyrosine kinase inhibitors, it is acting on the level of proteins. It is acting on the level of the tyrosine kinase, inhibiting its effect. It is not at all acting against the BCR-ABL gene, neither it is acting against the messenger RNA of the BCR-ABL gene. So what does it mean? It means that since it is not acting on the BCR-ABL gene complex and its mRNA product, so it will have no effect on the CML cell. Now, CML cell will be defined as the cell which has got a BCR-ABL gene complex, but which is not producing tyrosine kinase protein. So if the cell is quiescent, it is lying still, it, like the cancer stem cells does, this drug will not act on it, unfortunately. So the CML cells can evade. Next slide, please. Next slide, please. So the CML cells can also evade the effect of tyrosine kinase inhibitors. Yeah. So next slide. Now, how does a CML cell become resistant? A CML cell can become resistant by changing the tyrosine kinase. Now, tyrosine kinase is a protein. So just by changing the structure of the tyrosine kinase, it can become resistant. It can also become resistant by decreasing the import of the imatinib or other tyrosine kinase inhibitor, or by increasing the cellular efflux of the tyrosine kinase inhibitor, thereby reducing the concentration of tyrosine kinase inhibitor inside the cell. Or it can also become resistant by increasing the production of tyrosine kinase. So these are the three important mechanisms. There may be other mechanisms yet to be diagnosed, not yet diagnosed, that how the CML cell becomes resistant. Now, resistance can be divided into two primary categories, that is the primary resistance or the secondary resistance. The logic behind is that initially all the patients are, all the cells, or CML cells are sensitive to this imatinib, but over the time when the cells are proliferating, the newer cells are producing, random mutations are occurring, then definitely it is one particular subclone of the cells can get resistant by one of those above or the before and mechanism which I've told. Now, the primary resistance is a resistance where, please don't change the slide, previous slide, please. Yeah. So the primary resistance are resistance where the TKIs, they fail to achieve the desired response. And about 25% of patients with CML-CP, which are treated with imatinib, they fall in this category. That is, at the start only, these patients are resistant to it. Then the second group of resistance, which is much commoner, is the relapse, which is following an initial response to our TKI. Approximately 8% at 2 years of patients in CP who are treated with imatinib, they fall in this category. The most important cause of resistance is the compliance. The second important cause is your tyrosine kinase domain mutation. And then the other causes are, as I've already mentioned before. Next slide, please. Now, it is important for us to understand that the TKIs, that is tyrosine kinase inhibitors, they don't cure the disease. They don't cure the CML. Why they don't cure the CML is because they do not act on the genetic level. They do not act on the messenger RNA level. So they are only curing or they are only acting on the cells which are actively producing the tyrosine kinase protein. What they do, these tyrosine kinase inhibitors, they do is that they decrease the CML cell load in the body. And once the CML cell load is decreased in the body, there is decreased chances of mutations, those random mutations, which lead to the differentiation block. So they decrease the chances of disease transformation into blast crisis. This is how this TKIs, they act. So physiologically speaking, these cells, these agents, they are not supposed to cure a patient of CML. Next slide. These TKIs, they have ushered a new treatment paradigm in the cancer therapy. Now, what is happening is that what scientists are doing nowadays is they're identifying a pathogenic protein and they are getting some targeted therapy against it. There have been a tremendous number of new targets which have been identified, and their antidotes, that is the treatment molecules, which have been identified. But it is important for us to understand that all this therapy, these targeted therapies, they are acting against a particular protein. Underlying genetic signature of the cancer cell, it remains unchanged. That is what is important. So these therapies are not curative in nature. Secondly, ultimately, these cells, they escape because newer cells, newer subclones, they devise ways to escape the effect of these targeted therapies, and then they lead to the generation of resistance. Next slide. The treatment of patients on TKI is very simple. We continuously give this treatment with TKI. The patients are treated with TKI continuously with continuous monitoring at regular intervals to look for the disease load. Till the time disease is in the acceptable limit, we keep on giving this drug. And if the disease starts to increase, then we either increase the dose or we switch over to other TKIs after finding out whether the compliance has been good. And how do we monitor the disease load? We monitor the disease load by looking for these abnormal DNAs by various techniques. Next slide. However, till now I have been telling about this concept that this TKIs, they are non-curative. You can't cure a disease with TKIs or with protein-based therapy. But over the last decade or so, it has been shown that patients who are having long-standing treatment with TKIs with almost zero CML load, even after stopping the TKIs, around 50% of these patients, CML loads, they stay near zero and they do not increase. Now, initially, when I saw these results, I was astounded. Why? And why? Because physiologically, this is not possible. Philosophically, this is possible. But still, something else was happening inside the body of these patients, where these patients' CML load either stayed zero or they increased up to a level and then they plateaued to that level, not causing any harm to the patient. So this is another very important concept that is coming in, that is the concept of treatment-free remission in these patients of CML, in who have been treated with TKI with excellent results with almost zero CML load, and then we see that even after stopping these TKIs, these patients, their disease is still either at zero or at very near to zero. What is the possible reason for the same? People are yet understanding the reasons, and maybe one of you can find out the reason for the same. Next. So now other approaches. The other approaches of treatment of CML is very, very minuscule at present because of this group of drugs, the targeted therapy that has started with CML. Now people are just designing newer and newer targeted therapies of that same ABL gene product, which is there. Different areas of the gene product has been targeted. But the newer approaches, the other approaches will be an immune therapy for CML, which has not yet been successful. That is training the immune system against the cancer cells. Two most important immune therapy is bone marrow transplantation, as already told by Dr. Biju George, and Dr. Naveen Kadri also told about that excellent and the initial this new field of CAR T cells. So this immune therapy is another very important approach of treatment for cancers, which can also be applied to CML. Important thing to note is that this immune therapy is also protein based. It is also acting against a given protein, so it will have all those things that it will not be curable permanently, or it can be curable by a maintenance sort of a thing. So that is one approach, that is the immune therapy. Second, the DNA-based therapies, treatments, many of which I have not been able to envisage what is going to happen over the next few decades. And this DNA-based treatment will be for you all to discover and to find newer ways to treating CML and to treat cancers in a newer way. Thank you. Next slide, please.
Thank you very much. Yeah, I'm not muted, I think. Okay. Thank you very much, Dr. Suman, for that excellent talk on chronic myeloid leukemia. I think that has covered most of the questions that students had, taking us from the history to the current treatment and to the futuristic treatment options in CML, including other advanced treatments. It's been a pleasure always listening to your session. And our student team is going to contact you more for your biostatistics classes, I think. So
yeah, definitely.
So, I think with that we come to the end of the panel discussion. I'm sorry that it got delayed, but it was an excellent session, very informative session.
No, it was really excellent. Really excellent.
Yeah, so I think I take this opportunity to thank all the three panelists, Dr. Suman Pramanik, Dr. Naveen Kadri, and Dr. Biju George, for their excellent discussions on the respective topics. And I also want to thank my co-moderators, Dr. Karthika and Dr. Princey. It was a lot of good learning for me. And as I would say, Richard Feynman was a great teacher, and we saw quite a great number of teachers here today. And the best way to learn is to teach. And I think we've hopefully, been able to, create some sparks in the mind of the students out there, and we'll definitely, see some of them, doing advanced CAR therapies, CML therapies, and bone marrow transplants in the future. With these words, I thank you once again, Dr. Suman, and I invite Arunima for the concluding remarks. Thank you very much.
Thank you. Thank you.
Thank you for being a part of today's panel discussion. I would like to thank all our panelists, Dr. Biju George, Dr. Naveen Kadri, and Dr. Suman Kumar, and our moderators, Dr. Neeraj Siddharthan, Dr. Princey Lewis Palati, and Dr. Karthika, and our 2018 MBBS batch students, Anju Anand, Naina Joseph, and Aditi Arora. Now, I would like to extend my sincere gratitude to our principal, Dr. Colonel Vishal Marwaha, the organizing committee, AV team, and support staff for their constant support and hard work. We could not have pulled off this session without our sponsors, Roche. To know more about our upcoming events, you can log on to www.spasht.co.in and also contact us via our social media platforms like Instagram, Facebook, and LinkedIn. Thank you.